Welcome back to the last session of the day. We are going to start from where we left. So, of course, if you hear and if you can see me, you can give a yes or thumbs up button. Yes, thank you. So you can hear. Cool. So we are on the way to discover the MCA territory process. So let us finish off that. So if you want to really know what are the branches that we have been discussing for the superior division, because superior division branches becomes really important in this setting. So this branch that what we have been discussing is going to be the pre-Rolandic and orbitofrontal branch. For example, if I want to write here, I can write this is an orbitofrontal branch, and this is going to be the pre-Rolandic one. And this branch, the one which we have talked about, is going to be the Rolandic branch. Rolandic branch. So this is the pre-Rolandic one. And then we also have the anterior parietal branch and posterior parieto-temporal branch. This is the anterior parietal. And we have one more branch called posterior temporoparietal, or you can call it as posto-temporal branch. I mean, even though it's not exactly located in the anatomical sense, but still this will give you an idea. So what are the branches? And in the inferior division, you have a lot of branches, like you have anterior temporal branch, posterior temporal branch. So if you really want to know, I can draw like this is an anterior temporal. Sorry, this is posterior temporal. And probably you have an anterior temporal branch as well. So some examples of what are the branches that we have been discussing. Now it's important to look out for the causes. I mean, look out for the effects of the damage of different areas. For example, you know what's going to happen if you're going to get damage to the Broca's area. I mean, since we have been talking about the left side, so that's going to result in something called a Broca's aphasia. You know that. And you know what's going to happen if you have damage to the Wernicke's area. That's going to result in something called a Wernicke's aphasia. And if at all you're going to have a damage to the arcuate fasciculus here, so you're going to result in conduction aphasia. All right, that's understandable. And suppose if you have damage to the angular gyrus, so what are the problems you're going to encounter? So angular gyrus is basically in the parietal lobe. So if you have damage to the angular gyrus, so what are the problems that you will encounter? So it depends on whether you are damaging the left side angular gyrus or the right side angular gyrus. Suppose if you are damaging the left angular gyrus, which means I'm talking about a dominant angular gyrus. So damage to the dominant angular gyrus is going to result in something called the Gerstmann syndrome. We know that. So what are the components of a Gerstmann syndrome? Everyone should be familiar about the components of the Gerstmann syndrome, which I've been studying from the first year, isn't it? In the anatomy and the physiology textbook itself, it's there. Yes, Gerstmann syndrome is basically syndrome of acalculia, then agraphia, where you have difficulty in writing. Acalculia means difficulty in calculation. Then you have left-right confusion. And finally, you have a peculiar type of agnosia where the patient has problems in identifying his or others' fingers. That's called a finger agnosia. So these are the four categories which are, and in this, the finger agnosia is something which is very difficult to explain because even neurologists are not able to explain why that peculiar finding. But nevertheless, Gerstmann syndrome is a tetrad of four findings: acalculia, poor calculation; agraphia, that is poor writing; then left-right confusion; then you have finger agnosia. So when we move on to the dominant hemispheric functions and the non-dominant hemispheric functions, which you have discussed already. Where is that? I think I have rubbed it off. Dominant and the non-dominant hemispheric functions. So now you can also make out the fact that that dominant hemisphere does calculation. We know that. Which lobe of the dominant hemisphere does the calculation? Of course, it's the angular gyrus, which is typically located in the parietal lobe. So which means this writing and calculation function of the dominant hemisphere, if you really want to localize where it is located in the parietal lobe. So that is also proven by this. And apart from that, if you have a right side non-dominant parietal lobal involvement, what are the problems you will get? Typically, you will lose the 3D abilities, so that three-dimensional functions will be lost. The creative skills, that's what the most important thing is. So you will be resulting in something called a constructional apraxia, characteristically. And it can also result in something called a dressing apraxia, which I told you already. So this will be the effects of non-dominant parietal lobe involvement, especially the angular gyrus involvement. Apart from that, as a whole, if I tell you what will happen if you involve the non-dominant parietal lobe, especially the most posterior portions, as a whole, I'm talking about now non-dominant parietal lobe involvement. So I cannot show you with this particular diagram, so I'm writing it separately. So non-dominant parietal lobe involvement, what are the features? Non-dominant parietal lobe involvement. Just hold on. Sorry. So whenever you have a non-dominant parietal lobe involvement, so what are the features that are going to get in a non-dominant parietal lobe involvement? Ishan is asking, Gerstmann syndrome is a parietal lobe lesion or angular gyrus? First of all, you have to understand angular gyrus is present in the parietal lobe. So non-dominant parietal lobe lesion, and what's something you're going to get? Hemifacial neglect. So remember, the idea is to understand that the patient will have some kind of neglect on the left side. So milder forms of non-dominant parietal lobe involvement may have something called extinction phenomenon. So somebody should somebody should tell what do you mean by extinction in the first place. And at the same time, severe cases may result in something called a complete neglect. That is what we refer to as a hemispatial neglect, not facial. Hemispatial neglect. And remember, this typically happens only on the contralateral side. This does not happen on the ipsilateral side. This typically will happen on the contralateral side. So first of all, what do you mean by extinction? That's the question which you didn't answer. So let me tell you sequentially, what do you mean by extinction? First of all, you try to call me from this side. I know somebody is calling me from this side. This is my right side for your information. If somebody is calling me from my left side, I know that somebody is calling me from my left side, so I turn this side. If somebody is stimulating me from both the sides, even though I'll be turning to one side, but I know that my stimulus is coming from both the sides. So I'll be aware that even though the stimulus is simultaneous, I'll be able to localize that stimulus. So this simultaneous stimulus, when you're able to identify, that is something is a function of the parietal lobe again. So in the setting of a non-dominant parietal lobal injury, the patient will have a dysfunction in identifying the stimulus that is coming from the other side, that is contralateral side. So most often it will be the right parietal lobe that will be the non-dominant one. We know that dominant is always the left. So when you have a right parietal lobe involvement, so the patients will be having difficulty in actually identifying simultaneous stimulus, especially that is coming from the left side. So for example, if I'm calling from the left side, only the patient will be able to identify. So that is my stimulus is coming from the left side. But the stimulus, if it's coming from both the sides, patient will ignore the stimulus that is coming from the left side, and they will only give attention to the stimulus that is coming from the right side. So this phenomenon is what we refer to as something called a neglect phenomenon. Remember, that is what we refer to as a loss of extinction. So, or a milder forms of extinction. So that is what we refer to as a neglect. So whenever they ask, what do you mean by extinction? So which means my inability to identify simultaneous stimulus when it applied on both the sides. So that's what we refer to as something called a loss of extinction, and that can be also called as something called a neglect in a way. But in extreme forms, what we call it as an hemispatial neglect. So what do you mean by hemispatial neglect? Which means the patient tries to ignore whatever that happens on the left side, which means whatever that happens on the contralateral side, he will ignore. In the sense, in extreme forms of parietal lobar involvement, which means in very, very severe cases, the patient may not shave on the left side. He will shave only on the right side. He will ignore on the left side. So when you take a plate, he will eat food only from the right side. He will ignore food on the left side. When you ask them to draw, like the numbers in a circle to make it a clock, so they'll be drawing something like this. So this is how they will draw the clock. So these are extreme forms of neglect. This is what we refer to as hemispatial neglect. This can happen in very, very severe forms. But milder forms of neglect is what we see very commonly in the form of extinction, where the patient will still be able to respond to the stimulus that is given on the left side. But when it is simultaneously applied, he will ignore the stimulus on the left side and persistently he will be looking for the right side stimulus only. This is what we refer to as a contralateral loss of extinction, or otherwise referred to as a contralateral neglect. Hemispatial neglect is an extreme or a severe form of your neglect, that where the patient completely ignores what is happening on the left side of the world. He will be concentrated only on the right side, which means non-dominant parietal lobar lesions will typically result in something called a neglect. So you can extrapolate that in milder forms as well as severe forms. That's the most important thing. Apart from that, the non-dominant parietal lobar involvement, even half side of the clock can't be drawn in neglect. No, you are drawing right. So you are ignoring only on the left side. So which means only one area will be ignored. It is not like you will be ignoring the entire side. So on the right side, you will be doing it better. On the left side only, you will not be able to do it. So this is what we refer to as a contralateral neglect. So this is not going, neglect is not going to happen for the entire spatial dimension. Only on one particular side, you will get the neglect. Why ignored? Because that is considered to be the function of the non-dominant parietal lobe, basically, that 3D identification, spatial orientation, which I have discussed already. And apart from that, conduction and dressing apraxia. What is conduction? I don't know. We are talking about construction apraxia. This is not conduction. Construction apraxia is a feature of a right non-dominant parietal lobar involvement again. Especially if the lesion is in the angular gyrus in the parietal lobe, you are going to get construction apraxia and dressing apraxia. So now we know what is going to happen if your angular gyrus is damaged. On the dominant side, remember angular gyrus is on the parietal lobe. If it's going to be on the dominant side, you're going to get Jessamine syndrome. Non-dominant side, you will get more other problems like construction apraxia and dressing apraxia. And non-dominant parietal lobar lesions, apart from getting a neglect, they can also result in something called a anosognosia. What do you mean by anosognosia? What do you mean by anosognosia? Non-dominant parietal lobar lesion. Yes. No, that is not anosognosia. Inability to identify their own illness. So for example, this is very commonly seen in a stroke patient, especially extensive MCA territory infarct, especially if it's on the right side territory, MCA territory, because it's going to happen from the non-dominant side only. So they will not be able to move their entire left limb at all. So during the rounds, you go to those patients and ask them to move the left hand. So what you will say usually, the patient, what they should say, if you ask them, and because the left leg and left arm is paralyzed, if you ask them, they should say like, I cannot move my left limb because I got a stroke. That's what you expect the patient to answer. Or the patient will try to move the left limb, but they will not be able to move it. So and they will tell, I cannot move it, sir, I tried. But what these guys will do, anosognosia guys, is they will try to use the right hand and they will try to lift the left hand and show, see, I will be able to move the left hand. So they believe that they are still able to move the left hand, but they're not even aware that they're using the right hand to move the left hand. So this is a peculiar type of sensory mal-identification, in the sense like they will not be able to identify their own deficits. That is what we refer to as anosognosia, which typically happens in the setting of a right parietal lobar involvement, again, non-dominant parietal lobe, a non-dominant hemispherical problem. So then we have many other areas whose involvement will result in a lot of other things as well. So let us start with maybe the frontal eye field. Suppose if you have a frontal eye field damage, so what you will be getting? So remember, frontal eye field is important for contralateral gaze preference. Contralateral gaze preference. So what do you mean by contralateral gaze preference? I mean, everyone talks about horizontal eye movements, fine, but I'm not talking about that. I'm talking about a contralateral gaze preference, which means, let us assume in a very easier way. So suppose I'm walking in the road, and when I'm seeing some good stimulus coming from my right side, so which means maybe some hot girl is moving in front of me on the right side. So naturally, it's my, yeah, Shubham is telling curves. Okay, some curve is going towards the right side. So let us use that word itself. So I want to see on the right side. But it's my natural intensity, you know, it's my natural tendency to see that side because my hormones are stimulating me. So I saw on the right side, but suddenly after that, I started realizing that it is my ex-girlfriend. So what I will do, I'm going to turn towards that side. Okay, that's what is going to happen because I don't want any more complications in my life. Already it's complicated enough. So I don't want that. So this is what is going to happen. So here, voluntarily, I am trying to push my gaze towards the left side. And that's what the frontal eye field does. So this is a voluntary gaze preference. So remember, for moving the eye towards the right side, involuntary, like subconsciously, I don't really need my frontal eye field, but for voluntary gaze preference, I need my frontal eye field. So if at all my frontal eye field is damaged, so what will happen? Frontal eye field is damaged. I'll not be having that contralateral gaze preference. Instead, I'll be having ipsilateral gaze preference. That's all. It's opposite of that, which means if my right frontal eye field is damaged, I'll be always trying to look towards the right side only. My gaze preference will always be towards the right side. Voluntary, I'll not be trying to look on the left side at all. That is because my right frontal eye field is the one that pushes my voluntary gaze towards the left side. So I will not be having any motivation to look towards the left side or moving my eye towards the left side. That is what happens. This is what we refer to as ipsilateral gaze preference. If my frontal eye field on the right side is damaged, I'll be always looking on the right side. Suddenly, if you give some rapid stimulus or something, I'll be able to turn to the left side, but it will be very momentary. And again, my gaze will be shifted towards the right side, which means it is not a paralysis, which means my eyes still are able to move towards the other side. It's like a preference. So I wanted to look more towards the right side. So this is my right-sided gaze preference. So that's what we refer to as an ipsilateral gaze preference. So this is what happens in the setting of a damage to the frontal eye field. Fine. So of course, you know what's going to, I'm not going to tell. Of course, you know what's going to happen if you damage the primary motor cortex. You're going to result in contralateral hemiparesis. Depending on which vascular territory, you'll be having preference towards arms or legs. All right. So, and again, if I'm going to damage the primary somatosensory cortex, that is a primary sensory area, then I'll be having contralateral hemisensory loss. Typically, more importantly, I'll be losing the cortical sensations. That will be the most important thing that will be lost, which we'll be discussing after some time. What do you mean by cortical sensations? In some 15-20 minutes, I'll tell you. And apart from that, if my premotor cortex is damaged, so what will be the result of premotor cortex? There is a type of apraxia called as limb kinetic apraxia. I'll tell you the difference between each and every apraxia in some time. That's called a limb kinetic apraxia. That's what you will get if you have damage in the premotor cortex. Again, partly it is in the ACA territory and partly it is in the middle cerebral artery territory. Remember, if you specifically get problem in the anterocerebral artery territory, suppose if you specifically get this premotor cortex damage within the anterocerebral artery territory, you will result in a particular type of apraxia called as gait apraxia. And that's why I told you, I mean, anything that is concerned with the legs is going to be anterocerebral artery territory, in fact. So gait apraxia is specific for ACA territory. In fact, even though it can happen in many other conditions like normal pressure hydrocephalus and even frontotemporal dementias, but as far as stroke is concerned, the most important reason for gait apraxia is ACA territory, in fact, because this area that is supplied by the premotor cortex that is supplied by the ACA territory is involved with the leg coordination. So that's why you get gait apraxia. Otherwise, MCA territory, in fact, typically will result in some diffuse type of apraxia called as limb kinetic apraxia. Then what else is there? Suppose if you get damage in the inferior parietal lobule, we have discussed already. If you get damage in the inferior parietal lobule, so what will be the effect of the inferior parietal lobule damage? sensory cortex damage, I told you only hemisensory loss, right? I didn't tell you hemiparesis. It will not result in hemiparesis. It's hemisensory loss only. Okay, what will be the problem if you have damage to the inferior parietal lobule, IPL? No, really. Yes, typically you will result in something called a ideomotor apraxia. That's what you will result. You will result in something called ideomotor apraxia. I'll tell you what is ideomotor apraxia in some time. Similarly, you will get, suppose if you are going to damage the superior parietal lobule, you will be resulting in some specific problem that is called as Balin syndrome. I'll tell you what is Balin syndrome, because this superior parietal lobule is located in the watershed territory, basically. If you see, it is located in the watershed territory between the PCA, posterior cerebral artery, and the middle cerebral artery. So basically, it's going to result in some form of a watershed infarct. Either you will get a Balin syndrome complete component, or some of the few components of the Balin syndrome you will be getting. I'll tell you what are the components of Balin syndrome in some time. So that is the problem you will get because of the damage to the superior parietal lobule. Balin syndrome, B-A-L-I-N-T, balance. So that is the problem that you're going to get because of damage to the superior parietal lobule. Of course, fine. So you got Balin syndrome. We have discussed all these things. Then what else we have not discussed? Yes. And in the temporoparietal junction, we have another area, non-specific, temporoparietal region. So for example, you have an area called this junction between the temporoparietal region. This area doesn't have much any name. And for example, if you have damage to this temporoparietal region or parietotemporal junction in the posterior side, you're going to result in a type of apraxia called as ideational apraxia. Ideational apraxia. Clear? So Rijo is asking ipsilateral and special lesions produce, ipsilateral, what are you asking? IPL and SP lesions produce contralateral effects. No. All these are dominant hemispherical lesions. That's why I'm telling here. Except the frontal eye field, which you have discussed, most of the things what I have told you are dominant hemispherical lesions. For example, this limb kinetic apraxia, typically you will get when you have problems on the left side. And Balin syndrome, typically you will get when you have problems on the left side. And ideomotor apraxia, ideational apraxia, all these things you're going to get typically when you have problems on the left side, not on the right side. On the other hand, if you get problems on the primary motor cortex, then contralateral hemiparesis can happen on either side. So that's not specific, left or right. Similarly, hemisensory loss can happen on the right side or left side, doesn't matter. Similarly, this contralateral gaze, ipsilateral gaze preference can happen either on the left side or right side, doesn't matter. We have not talked about any right side lesions till now. But one specific thing that can happen on the right side. So if anyone wants to tell, they can tell. So usually I wanted to locate the lesion at this point. This point may be in the inferior aspect of the temporal lobe. So, this is a very vague area. I don't want to really tell because it cannot be seen on the lateral surface. Just for understanding purpose, I'm putting some area on the inferior aspect of the temporal lobe. If you have problem in that area, that's not insula. Insular cortex is on the frontal lobe. When you remove the, between the frontal and the temporal lobe, you will see the insular cortex inside. That is, insula is different. No, this area is the inferior part of the temporal lobe. And this is concerned with something called a non-verbal memory. That's concerned with non-verbal memory. The moment I tell non-verbal memory means that should be on the right side. So which means I'm going to talk about a right-sided lesion, non-verbal memory. And the damage to this particular area that is present on the inferior part of the temporal lobe can result in loss of non-verbal memory, especially, yes, problem in identifying faces. So what is that called as? That's called as prosopagnosia. Prosopagnosia, right? So that is inability to identify faces. When this is an extreme form. Sometimes they'll not be able to identify even their own wife by seeing a photo, but they can be able to identify by hearing their voice. They will be able to identify probably by touching them and seeing. So this is an extreme form of facial mal-identification. So only for faces they will not have a proper identification. So that is what we refer to as a prosopagnosia. That happens usually due to damage to some inferior portion of the temporal lobe. And you can clearly see which territory that is located in. That's a PCA territory or MCA territory or ACA territory, where it is located in. You'll be able to answer. till now, everything we have seen in the MCA are probably some things in the ACA territory only, but of course, this happens due to PCA territory infarcts. And of course, we know because this is a form of non-verbal memory, that's going to be due to the right PCA territory infarct, not the left PCA territory infarct. Till now, so many things we have seen for the left: Gerstmann syndrome, ideomotor apraxia, ideational apraxia. So I've seen a lot of stuff. Yes, it's near the fusiform gyrus only, but location is not important. The term is very important: prosopagnosia. Clear? So that's a form of poor identification of face. Clear? So you have so many things which you have drawn here. So let us recap whatever we have studied. Prefrontal cortex, antisocial behavior, anterior cerebral artery. Kate apraxia, anterior cerebral artery, located in the premotor cortex, but on the anterior cerebral artery territory. If you have damage to the premotor cortex, you will result in limb kinetic apraxia, especially on the left side. Primary motor cortex, contralateral hemiparesis, either side. Primary sensory cortex, you have contralateral hemisensory loss, either side, predominantly the cortical sensations. And Broca's area, damage, left side, Broca's aphasia, middle cerebral artery territory, superior division. Then you have Wernicke's area, left side, Wernicke's aphasia is the result of damage, and it's located in the middle cerebral artery territory only, but inferior division. Angular gyrus, once again middle cerebral artery territory. Lesions on the left side, you will result in Gerstmann syndrome. We have seen already lesions on the right side, probably constructional apraxia, and you will result in dressing apraxia. But overall, when you take a non-dominant parietal lobar lesion, apart from the constructional apraxia and the dressing apraxia you can result in the form of loss of extinction I told you. That is what we refer to as neglect, which can be a very severe form called as complete hemispatial neglect as well. And apart from that, it can result in anosognosia, where the patient will be unaware of their own deficits, which I mentioned already. And in the dominant lobe, you have superior parietal lobule involvement, which will typically result in Balint syndrome, maybe the entire syndrome or some of its components. Or you can result in something called ideomotor apraxia if you result in damage to the inferior parietal lobule. Then you have parieto-temporal junction in the especially in the MCA territory only again. So damage to that area may result in development of something called ideational apraxia. Gate apraxia is also usually on the dominant side lesion only. Both sides usually will not cause. Dominant side usually causes gate apraxia again. Most of the things will be on the dominant side only. So ideational apraxia. So that is because of the damage to the parieto-temporal junction in the posterior aspect. That's all. And we have prosopagnosia. We discussed about prosopagnosia, which is due to damage to the inferior part of the temporal lobe near the fusiform gyrus, and it is due to right PCA, territory infarction, which we have discussed already. So now we have different kinds of apraxia, which has to be differentiated. For example, we have something called ideational apraxia. We have discussed that is due to damage to that parieto-temporal junction, MCA territory again. We have ideomotor apraxia, which is due to the damage of the inferior parietal lobule. Even though there are substantial differences, this is the common thing that every standard textbook gives. Then we have limb kinetic apraxia. Then we have the Gerstmann syndrome. So these are the 4 new terminologies that we have encountered in this particular session. So let us discuss one by one. So first of all, not Gerstmann, sorry, Balint syndrome. Gerstmann we have discussed already, Balint syndrome. So let's finish off the Balint syndrome first. Balint syndrome is basically a triad of 3 components. One is called optic ataxia. Second one is called oculomotor apraxia. And third is something called as simultagnosia. So usually Balint syndrome will happen due to watershed infarctions. What watershed I told you? At the PCA, MCA watershed territory. So that is where you get the Balint syndrome basically. So what is the watershed area basically? If you take 2 regions, so this watershed area is the area that is supplied commonly by both the arteries. For example, we take this is the MCA and this is the PCA. The supply will be like this, coming like this and going into like this, deeper. So which means whenever one particular artery is infarcted, for example, PCA or MCA is damaged, you will be resulting in escape of this watershed area, because this other areas may be affected, but watershed area will escape because of the bilateral supply that it is receiving. But where this watershed area will go for infarct is because this is the most distal area to both the arterial supply. So which means whenever you have a severe hypoperfusion states, like severe shock, especially in the setting of cardiac arrest, that is the place where your watershed areas will go for infarction. If it's unfortunate, they can go for infarction, especially in shock and cardiac arrest kind of scenario, because they are the most distal areas, because they are located in the overlapping areas. So that's why you might get watershed infarcts in the setting of shock and cardiac arrest, which can result in something called a Balint syndrome if the watershed infarcts happens in the MCA-PCA overlap region. So let us assess the components now one by one. So one is optic ataxia. What do you mean by optic ataxia? This is not due to cerebellar problem, please understand. If you examine the other components of cerebellum, it will be completely normal. But for example, if you take this pencil and keep it over here, and if you ask the patient to touch this pen or pencil, whatever, so what they do is they will be hovering around this area, so they'll not be able to touch at all. So spatial identification will be very poor. So this is what we refer to as something called a optic ataxia in the first place, very characteristic, peculiar, and other components of cerebellar involvement will not be there. Everything else will be normal. Only for vision, and that too, this kind of spatial identification, there will be some problem. So this is optic ataxia. And second, we have something called oculomotor apraxia. You know what do you mean by apraxia? Failure in executing something. So the motor movements is not able to be executed properly. That is apraxia. Oculomotor in the sense it's considering the eyes. So their eye movements will be incoordinated in the sense like they'll be trying to move their eyes, but they will feel a lot of difficulty in seeing something or fixing a gaze on something. So this is what we refer to as oculomotor apraxia. Then we have something called a optic ataxia. No, what you see there is completely different. I'll know what you're asking right now. That's not the cerebellar problem. This kind of optic ataxia is completely different. And you have something called as simultagnosia. So if you want to know the spelling, what I have written, that is simultagnosia. So you know that name tells it's agnosia, then the previous words tell it's simult. So what do you mean by simultagnosia? For example, if you ask these patients to identify, I'm missing the forest trees. No, not like that. So if you ask these patients to identify what is this, if you show this and ask them, they will tell, okay, this is a pen, this is a pencil. If you ask them what is this, they'll be easily able to tell this is a cell phone, obviously. But if I show both these together, what is this and what is that, they'll not be able to identify. So inability to identify simultaneously shown objects to them is what we refer to as simultagnosia. Again, it's a problem of identification. They cannot identify when the objects are given simultaneously to them. So this is a peculiar type of agnosia again, and this completes the triad of Balint syndrome basically. And most of the times in watershed infarcts, you may not be able to see the full component of Balint syndrome, but many of these individuals tend to have only this optic ataxia as a major manifestation. And then coming on to the other forms of apraxia, ideational apraxia. We know it's due to problem in the MCA territory only in the dominant zone in the parieto-temporal junction. So that's where the ideational apraxia area is located. So as far as ideational apraxia is concerned, it's also referred to as something called a conceptual apraxia. Conceptual apraxia. So what do you mean by that? So which means the patient will lose the ability to understand what are the importance of objects. So simple way, if you want to tell, they may not be able to understand that this pen is to write. So they will confuse this, probably this pen for a knife, and they will take this pencil or pen and they will try to cut the vegetables. So they will completely confuse. I mean, confusion is for the objects and confusion is for the kind of work they are going to do. So which means they don't have the concept. That's the problem here. So they don't understand the concept of what objects are used for what activities, and they also confuse the different activities that can be done with different objects. So basically, this is what we refer to as a conceptual apraxia or ideational apraxia, and this results in serious disability in day-to-day life, which means they will not be able to perform a lot of activities if they have this kind of disability. On the other hand, if you ask what do you mean by ideomotor apraxia, here day-to-day abilities will be okay, the patient will be able to do, but when you ask them to demonstrate, so that idea will not flow into motor activities. That's why it's called ideomotor apraxia. So which means they will have the idea, they will be able to do involuntarily, but they will not be able to do it voluntarily, in the sense like when you ask them to mimic, that's called pantomiming in neurology. So for example, I don't have anything in my hand, but you ask me how to, for example, use a scissor. What I will tell like I'll take the scissor and I'll be doing like this. So this is how I use a scissor. For example, how will you hit an object with a hammer? I mean, demonstrate it. We'll tell like this. So this is what we refer to as pantomiming, and this is imitation. So this kind of things is very difficult in ideomotor apraxia, which means they cannot take the idea that is already there into a motor flow. So this is ideomotor apraxia, but it will not result in serious disability because day-to-day activities, when they do involuntarily, I mean, as a routine basis, that's fine. They'll be able to do it, but they cannot pantomime. That's the most important thing. Pantomiming will be completely defective, will be lost. In the sense, like they will not be able to mimic it, and they will do it in their routine examination. So that is what we refer to as a ideomotor apraxia. And you have a limb kinetic apraxia. And the most important difference with that of the ideomotor is because many people think like ideomotor and limb kinetic are almost the same because both are happening in completely different areas, but there is a lot of difference between them. Here also there will be problem in doing things, and the almost same thing like ideomotor apraxia, but that voluntary autonomic dissociation will not be there. So where in ideomotor apraxia, you're actually seeing something called a voluntary autonomic dissociation. But whereas in limb kinetic apraxia, there is no voluntary autonomic dissociation, whether you ask them to do voluntarily or whether even in day-to-day life, whether they want to do something involuntarily, there will be serious difficulty. Once again, all the day-to-day activities will be affected in this also. So this is limb kinetic apraxia, and they will see serious difficulties in performing tasks. It's not related to motor power, of course. This is something completely different. So in ideational, the concept of objects itself is lost. Whereas in ideomotor and limb kinetic, the concept of objects will still be preserved. They know what to do at what place, but they'll not be able to execute it. If there is a voluntary automatic dissociation, then it will be called as a ideomotor apraxia. If there is no voluntary automatic dissociation, the patient has deficit in voluntary as well as autonomic activities, then that will be called as a limb kinetic apraxia. Usually, we follow a classification system called Liebman classification system. So Liebman is the one who gave a classification system for apraxia, where he told many different types of apraxia, including gait apraxia, constructional apraxia, so many different types of apraxia he explained. That's a Liebman classification system. But right now, like we have discussed a lot of types of apraxia. Gait apraxia, I mean, it's nothing but the problems in the gait. Walking will be very defective. That is gait apraxia. In ideomotor, patient will use scissor involuntarily, but can't do when asked to do the same. Yes, exactly. That is the problem. The patient will have the idea to do itself, but when somebody asks to verbal commands, they will be having serious difficulty. They will not be able to do that. So idea to translate into motor activity is what is defective here. So that is ideomotor apraxia. Correct. So ideational, ideomotor, limb kinetic, gait, constructional, then what else? So many types of apraxia we have discussed already. This must be enough for your exams. So we have discussed a whole lot of things. So, like this one particular diagram which I've showed itself must be more than enough to answer so many questions in the exam, because this is a very high yielding diagram which has a lot of questions which can be covered in anatomy, physiology, as well as your medicine purposes. And we have not yet told about the superior division versus inferior division. Suppose if MCA proximal involvement is there, means it can produce anything. So proximal means your lenticulostriate branches will be gone, because if there is a thrombus at this area, for example, this is the M1 segment. So it can affect the lenticulostriate branches, it can affect the superior division, it can affect the inferior division. So it will be diffuse. Many times the patient will come with global aphasia if it's happening on the left side, and patients may have severe contralateral hemiparesis and contralateral hemisensory loss. And a lot of other deficits can be there depending on how much area in the brain is affected and how much plasticity is there and how much overlap between areas is there. Based on all those things, your disabilities will vary from patient to patient. But nevertheless, hemiparesis, hemisensory loss, and patient will be having mostly a global aphasia if it's involving the left side, and whatever the problems we have seen till now may be there. But remember, whenever you are going to have a superior or inferior division infarction, specifically if you have superior or inferior division infarction, you will result in some specific defects. You know what you're going to get. For example, let us assume this MCA is involving the superior division. Whenever MCA is involving the superior division, so typically you will be resulting in something called Yes, of course, it's very simple. You will result in contralateral hemiparesis. And of course, because it's a large vessel involvement, cortical involvement, your arm and face weakness will be more than the leg weakness. We know that. And feet will be spared for sure. And you will have a Broca's aphasia. Suppose if the involvement is on the left side. Otherwise, you will not have Broca's aphasia. And third thing that you can get is, you can get contralateral hemisensory loss also because of the sensory cortex involvement. And of course, you can result in other problems like maybe Gerstmann syndrome, if you're going to involve the angular gyrus, depending on a lot of other factors. But as a whole, we can expect the patients to exhibit Gerstmann syndrome if it's a full superior division infarction. And many other things, like for example, if the infarct is extensive, then they can develop the ideomotor apraxia as well as ideational apraxia also, if the infarct is extensive. And more importantly, they can result in something called a ipsilateral gaze preference, that is due to involvement of the frontal eye field. And number 6, they can also result in the development of something called visual field defects, that is due to involvement of the optic radiation that is passing through the parietal lobe. We told that is called Baum's loop. So they might have a homonymous hemianopia. If you want to really be specific, they can produce homonymous hemianopia with a special type called as inferior quadrantanopia, because it's involving the parietal lobe, superior fibers. Pitts, mnemonic is there. So these are the features of the superior division MCA infarction. As far as the inferior division of MCA infarction is concerned, usually will result in Wernicke's aphasia. Wernicke's aphasia, if the infarct is on the left side, on the right side, you won't get Wernicke's aphasia. On the other hand, if the patient is having, usually the patient will not have hemiparesis. Usually hemiparesis is very, very rare in inferior division infarction. They can have hemiparesis. Some muscle weakness can be there because of the overlapping blood supply to certain areas in the motor cortex, but generally they won't develop any hemiparesis. It's extremely rare in the setting of inferior division infarction. And as a whole, inferior division infarction alone itself is extremely rare. You don't get this kind of picture, but very rare. They can get other problems also. But 2 more things we have not discussed. I didn't tell you the association areas. Where are the association areas basically? Suppose if you ask the sensory speech association area, where it is located. So usually that is located in the inferior part of the temporal lobe. For example, this is the place where you have the sensory speech association area, where you will result in something called a transcortical sensory aphasia. We know that. I told you already. If you take the previous aphasia table and see, I have told that this sensory speech association area, transcortical sensory aphasia, is basically located posterior and inferior to the Wernicke's area, where it is supplied basically by the PCA, or probably by the watershed area between MCA and PCA. And you can clearly see where the association area is basically located. And if we take the motor speech association area, it will be located in the anterosuperior region. So I can draw here somewhere. So this is going to be the motor speech association area. So where it is basically located in the anterosuperior region to the Broca. So anterior and superior. So correct, isn't it? So that's why I told you. So typically this motor speech association area causing transcortical motor aphasia is located in the ACA territory. That's why we studied here. So this motor speech association area is located anterior and superior to the Broca's area. That's going to be the site of infarct, which is basically supplied by anterocerebral artery. So I think in this one diagram, I compressed as much as possible so to understand things much better. So I think this must be enough. So for your exams, most of the questions will be revolving around this particular diagram only. So revise this diagram carefully and go when you're going for exams. Of course, whenever I have a small vessel stroke like lenticulostriate involvement alone, any lenticulostriate involvement for that matters, will be having dense hemiparesis, and they'll not be having any cortical symptoms and signs, which means that arm and face business will not be there. Everything will be equal most of the times. And of course, the most important thing is the no cortical symptoms and signs. We have seen so many cortical symptoms and signs. All this Balint syndrome, anosognosia, prosopagnosia, then ideomotor apraxia. The word you tell apraxia means all these are cortical symptoms. And none of these things will be there in small vessel strokes, especially when you're going to involve internal capsule stroke. It's not going to be happening anyways. So that's how you're going to answer in exam. Whenever they ask you, how will you tell it's an internal capsule stroke or a lenticulostriate stroke or a small vessel stroke or a subcortical stroke or a lacunar stroke, the most important point is there is no cortical symptoms and signs. And the infarcts are likely to be showing a dense semiparesis where you don't have any difference between arm, face and leg weakness. And I think that should settle the debate for anterior circulation stroke. And now it is important to see the blood supply of the internal capsule. Do you understand till now whatever I told? I tried to make it as simple as possible. Yeah, that must be fine. That's all. Nothing else needed, basically. Okay. Now, let us take the internal capsule. Because when you take this particular section, for example, the same section. If you take this particular section, let us see this particular side internal capsule. You know, like this is the basal ganglia area, and you're going to get the internal capsule through this zone only. So this is how they're going to descend down. So first, keep that in mind. We are going to see in the coronal plane. Let us see what's happening here. Or in the, you can look at an axial plane also, no problem. So how internal capsule is going to be? First of all, let me conceptualize the internal capsule first. So for example, let me take primary motor cortex. This entire thing is the primary motor cortex. Because I'm drawing in this coronal plane, now I'm taking the primary motor cortex that is running here. So that is how you are going to conceptualize. So my entire primary motor cortex will be appearing like a strip, like an entire section. So if I cut in this zone, clear? So it means a primary, full of primary motor cortex. And of course, these cells are what we call as something called as bed cells, BETZ cells. I'm telling only about the corticospinal tract. This is not coronal, this is not sagittal. We are talking about a coronal plane. Sagittal is this section, isn't it? This is basically sagittal. When you see from this plane, you will be seeing only, like a part. So we're talking about a coronal plane. So we see the entire strip of cortex like this. So anyways, nevertheless, the concept is more important. So what's going to happen is these are the element neurons. These bed cells are called as element cell body. UMN cell bodies. That is upper motor neuron cell bodies. Then you have all these fibers are going to unite together. You can see. And they're going to be coming through a dense fibers, condensed in a dense area. And this condensed and densely packed fibers is what we refer to as an internal capsule here. It doesn't only apply for the motor, pathway. It is also for the sensory pathway, because the same thing, if you write in reverse, through the internal capsule only, your sensory information also goes up. So that's fine. So I'm drawing only the motor pathway for your understanding, but even sensory information is going to go in a similar way only through the internal capsule. So for example, this is the cortex. So for example, this is the primary motor cortex, and this is what we refer to as a corona radiata. Everyone knows that. For the motor pathway. For the optic tract, you're going to call it as an optic radiation. Similarly, for sensory pathway, you call it as a sensory radiation. So you have descending as well as ascending fibers to the cortex. So for example, if you put a lesion here in the cortex, so if you have this much big lesion in the cortex, so just to conceptualize, I'm telling, if you have this much big lesion in the cortex, probably see the number of fibers that are getting affected. Maybe in this particular example, 3 fibers are getting affected. So if I put a lesion in the internal capsule, the lesion size may be extremely small, but the problem is almost every fiber I'm affecting here. And similarly, since all the fibers are basically condensing to a point here, and here in cortex, you have this kind of difference. For example, the this area, for example, it's supplied by ACA. Remaining areas, it's supplied by middle cerebral artery. So that's fine. So as far as the cortex is concerned, that's fine. These kind of differences will be there. If it's MC-hereditary, in fact, you'll have more of arm and face weakness compared to the leg weakness. When you see these condensed tracts, when it comes to condensation and comes at the level of internal capsule, all the fibers are basically going to be affected. And you're not going to get any much difference. So that is what we refer to as dense semiparesis. Everything will be equal effect because everything has united together. Anyways, even though there is some differences there, which we'll be discussing, but nevertheless, you'll get a dense semiparesis. At the same time, the in fact, despite the size is small, the impact may be very severe because the weakness can be very severe despite the impact size being very small, because with the same amount of size, you are involving a lot of higher number of fibers. So that is the idea. So this is the first concept that you have to know behind the internal capsule. And with this, we can see the structure of the internal capsule. So how the internal capsule is there and what are the basic structure with regards to the internal capsule. For that, first, let me draw the internal capsule. On the left side, something like this. Everyone knows this, but just for understanding, I'm drawing. I'm purposely not drawing the sublentiform and the retrolentiform part. Superior parietal lobular and sensory speech association area are both watershed PCA MCA. Yes, of course, they're located in the, either you can tell it as PCA or you can tell watershed area of PCA and MCA. That's where it is located, correct only. So you have the anterior limb. So let us assume this is the anterior limb of the internal capsule. Then you have the posterior limb of the internal capsule. So now we are going for the axial sections, not for the coronal plane. So now we have understood the coronal plane. Now go to this axial sections again, where you have anterior and posterior. Because axial, if you take a cut, anterior and posterior. So you have the anterior limb and you have the posterior limb. Of course, yes. And the center part is what we refer to as the genu. And of course, like this is going to have different vascular supply, which we'll be seeing. But before that, we need to study what are the fibers that this internal capsule is taking care of. So first, let me divide into two, both these structures, like this. The central part and the peripheral part. And at the same time, I can divide here into further into anterior and posterior more. Okay. So now people are going to tell what is the central fibers I'm denoting here in the anterior limb of the internal capsule. So what I have drawn in black, they are actually thalamic radiations. They are going to the thalamus. They are ascending fibers. What I have drawn in black here. What are the ascending fibers? Because internal capsule contains both ascending as well as descending fibers. Both will be going through the internal capsule only. So ascending fibers, in the sense, this is going to be something called an anterior thalamic radiation. Anterior thalamic radiation. I'll tell you what does that mean really. But that's not really important. But more important is these fibers, which are present on either side of the anterior thalamic radiation. What are these fibers? These are basically descending fibers, which means internal capsule has both ascending and descending fibers. So what about these descending fibers? Yes, of course, more importantly, they are concerned with something called frontopontine fibers. Frontopontine fibers. So what are the functions of these frontopontine fibers? Why there should be frontopontine connection? So from the frontal lobe, you have connection to the pons. And they do some very important function called as sham function. Very important function called as sham function. So what do you mean by sham function? So yes, I generally call it as smile, which means that is emotions. And H stands for horizontal gaze. You need that because how can you otherwise control the contralateral gaze? So frontal lobe, I told frontal eye field is actually controlling the contralateral gaze. So these are the fibers that are coming from the frontal eye field, which goes to the pons and controls the cranial nerves to move the eyes towards particular side. And A stands for accommodation. And M stands for micturition. Clear? So which means these are the fibers that are coming from the paracentral lobule. So they are going to control the diffusion and micturition principle. So these are the sham functions basically that you have to know. Okay. First of all, let us understand why you need these fibers in the first place. So for example, if you have a frontal cortex and these fibers are coming and basically synapsing in the pons. In the pons, you have this famous 5, 6, 7, 8 cranial nerves. In that 6 and 7 are very, very important for two things. 7 is important for emotions and 6 is important for the lateral gaze. We know that. So that's why that contralateral gaze is there. So anyways, let us assume only 7th cranial nerve. 7th nucleus is there. So remember, this seventh cranial nucleus is not only influenced by the frontal lobe, it's also influenced by multiple other areas. For example, it is connected with the limbic system. It is connected with the primary motor cortex, which is a completely different area. I mean, we are talking about probably prefrontal cortex here. So I can write a PFC here. Prefrontal cortex, that's where your majority of the sham fibers will be coming from. So primary motor cortex is there, limbic system is there. So let us understand in a way like where maybe your HOD is scolding you. Fine. So your limbic system is telling the primary motor cortex to cry and to stimulate the facial nerve to activate muscles of crying probably. But at the same time, your prefrontal cortex understands that crying is very, very inappropriate at this point. So the, like the stimulation that is coming from the motor system will be bypassed, and this prefrontal cortex fibers, they are going to override the facial nerve and they're going to prevent you from crying because you think that crying is inappropriate at that point of time because many other students are there around you. Maybe. So this is how your prefrontal cortex is going to be helpful in your social roles. For example, when you sit in the cabin, your boss comes. Not boss comes. You are talking something about the boss. You are bitching about your boss. So you're telling like he's a waste man. You're talking something like that. Suddenly, when the boss comes inside, what do? Like suddenly, sir, good morning, sir. So how all these things happens? Because you have to override all these things because your social responsibility is there because this is needed. You can call it as this is acting, but still these are social responsibilities. Nobody can be just like what they want all the time. They have to manipulate their actions and they have to change their responsibilities at some point of time. So for that only you need this sham fibers, and that's where your prefrontal cortex comes into play. So that's why I told you smile, emotions, controlling emotions and changing emotions into different perspectives. So that is prefrontal cortex function. So these fibers will be coming from the prefrontal cortex, overriding functions where it will be manipulating the facial nerves action, and horizontal gaze. As I told you previously, from frontal eye field, it can manipulate your gaze by looking at something which you really want to look and you don't want to look. And the micturition can be controlled by paracentral lobule fibers, and of course accommodation fibers are also coming from the frontal cortex only. So these are the sham functions that are done by the frontopontine fibers. And of course you have this genu. Genu is mostly concerned with the like corticobulbar fibers. Corticobulbar fibers, or I can call it as a fibers that are supplying the facial nerve. So these are basically coming from the primary motor cortex only. So, but these are the descending fibers that are controlling the cranial nerves. These are called as corticobulbar fibers. And coming posteriorly, in the posterior limb of the internal capsule, these fibers which I have drawn in blue are the corticospinal fibers. These are the fibers that form the corticospinal tract. These are the corticospinal fibers, which are also coming from the primary motor cortex only. Clear? These are the ones that are going to form the future pyramidal tract. By passing through the crux cerebri, and they're going to form the pyramidal tract, and they're going to go into the spinal cord as corticospinal tract. And if you see the distribution, how they're distributed, for example, usually the arm will be located a little more anteriorly, then the trunk will be located little posteriorly, and the limb will be the most posterior. The lower legs. L means legs here, not the limbs. So arm little anterior, trunk in between, and leg fibers will be arranged a little posteriorly. So this is how the arrangement of the corticospinal tract within the internal capsule. Even though, remember, when you get an internal capsule stroke, you should not think about all these things. You are going to get a dense hemiparesis only. And what about these posterior fibers? A little more posterior fibers we are talking about. These must be basically ascending fibers, isn't it? This corticobulbar and corticospinal tract are basically descending fibers. We know that. And what are these fibers? These are basically ascending fibers. It should go up. Whatever I drawn in black are basically ascending fibers here. So what are these fibers? What are these ascending fibers? Going to the posterior limb of the internal capsule. No, retrolentiform we are not talking about. Posterior limb of the internal capsule. Yes, these are called as superior thalamic radiation. superior thalamic radiation, and this is a gateway for sensory pathway. These fibers are actually going towards the sensory cortex, primary sensory cortex, through the from the thalamus, through the internal capsule. They are going to the primary sensory cortex. Whatever sensations you have, spinothalamic tract, your posterior columns, all these things are converging at this point, and they're going towards the primary somatosensory cortex. So this is an ascending pathway, basically. So sensory tracts. Then what else? I mean, some other parts I have voluntarily ignored. For example, you have something called a retrolentiform part and sublentiform part. I don't want to really show, but I can show something like this here. So let us assume this is the sublentiform part of the internal capsule, and this is the retrolentiform part of the internal capsule. So what is the sublentiform? I mean, sublentiform is basically ascending only. There is no descending here. So if it's ascending, then what is the tract that it is carrying? What kind of radiation? Sublentiform part. They're going to carry something called inferior thalamic radiation. Inferior thalamic radiation. If it's inferior thalamic radiation, you can see inferior means it's in the temporal lobe, which means that should be concerned with the auditory cortex. So they are also called as auditory radiation. As far as the retrolentiform part is concerned, they are posterior thalamic radiation. So remember, posteriorly, if it goes, it must be optic only. So these are nothing but optic radiation fibers. The future optic radiation fibers are the ones that are going through this posterior thalamic radiation. I mean, as a posterior thalamic radiation through the retrolentiform part. And as far as the blood supply is concerned, blood supply is quite complicated, you will be knowing, but let me try to make it simplified. Just see step by step, then it will be easier for you. For example, if you take the internal carotid artery, and if you take, this is the middle cerebral artery, and from the internal carotid artery, you have other branches, like you have anterior choroidal branch also, which is one of the important branches of internal carotid artery. We saw that already. Then we have the anterior cerebral artery as well. So now what are the branches supplying what? So MCA is the only, like artery that is going to supply all the three, which means they can supply the genu, they can supply the posterior limb, they can supply the anterior limb as well. So which means these are the lenticulose triad branches of the middle cerebral artery. Clear? So they are small vessels. They are supplying the entire internal capsule, anterior limb, genu, posterior limb, everything can be supplied except for the sublentiform, the retrolentiform. Even they can have penetrating branches to the sublentiform as well as the retrolentiform part also. So as far as ACA is concerned, you have the recurrent artery of Hubner. That's a very important one. And that's going to supply the predominantly anterior limb. To small extent, they can supply the genu of the internal capsule also. But predominantly they will be supplying the anterior limb only. This recurrent artery of Hubner that is coming from the anterior cerebral artery. As far as the anterior choroidal artery is concerned, they will be predominantly concerned with supply to the posterior limb of the internal capsule. Predominantly, this anterior choroidal artery will be predominantly concerned with the supply of the posterior limb of the internal capsule. And at the same time, internal carotid artery can directly give lenticulose triad branches, which can supply the genu. And this anterior choroidal artery to small extent can supply the genu also. Which means what you're understanding here is genu is the only area that is supplied by everything. It is supplied by direct branches of internal carotid artery. It is supplied by anterior choroidal artery. It is supplied by middle cerebral artery. It is supplied by anterior cerebral artery also. Fine. Even though this diagram may look confusing, now if you follow step by step, it will be much easier. Then as far as the, you are going to get the posterior cerebral artery here, because here is the internal carotid artery, and here you are going to get the, let us assume it's the basilar artery. Basilar. This basilar artery is going to give rise to posterior cerebral artery. We know that on either side, you have posterior cerebral artery from the basilar artery. So this posterior cerebral artery can also supply small portions of the posterior limb of the internal capsule, but predominantly their supply will be to the retrolentiform part. You can again see which is concerned basically with the optic radiation. So they can supply the retrolentiform part of the internal capsule as well, but predominantly retrolentiform part only, but some posterior limb can be supplied by the posterior cerebral artery as well. Clear? Sublentiform part, again, it's confusing. Majority of the arteries will give multiple lenticulose triad branches, and they can form divisions to the sublentiform segment also, but that is not important. These are the important things that you have to understand. Yes, I mean, because there are so many branches are there. If you really see the 3D anatomy of the lenticulose triad branches, it will be like a grassroot that is coming out. in that particular area. So which means it's really difficult for any book to tell that this is going to be the correct blood supply. So it's not possible to tell for any book to have a correct blood supply. That's correct. That's because so many branches are there. These are small vessels also and cannot be seen by angiogram also. Then what do you expect? So how will you find out? So it's very difficult. Only in autopsy they have, and again it will be so much of variations will be there. Small vessels, so you cannot really tell. So to summarize, you can tell middle cerebral artery, anterior cerebral artery, internal carotid artery, posterior cerebral artery, and maybe I can write anterior choroidal artery and internal carotid artery. So I can write 4 proper areas of the internal capsule. Number 1 is the anterior limb of the internal capsule. Next is the genu of the internal capsule. Then we have the posterior limb of the internal capsule. Then you have the retrolentiform part of the internal capsule. Remember, we know genu is something that is supplied by all the branches except for the posterior cerebral artery. Genu is going to be supplied by everything. Let it be, doesn't matter, whatever may be the case. It can be supplied by all the branches of the internal carotid artery and its apparatus. Anterior limb can be supplied by MCA and ACA. Usually, these arteries do not supply the anterior limb, but predominant supply of the anterior limb is from the anterior cerebral artery only. Posterior limb is something that is predominantly supplied by the middle cerebral artery, but it can be supplied by to an extent by anterior choroidal artery also, but it's not going to be supplied by anterior cerebral artery or internal carotid artery or posterior cerebral artery. Retrolentiform part typically supplied by the posterior cerebral artery. That is what is going to supply the retrolentiform part. So this will give you a good clue about which arteries are supplying which areas of the internal capsule. And at the same time, there is so much of considerable overlap is there. This is an oversimplification of what is happening in otherwise complex anatomy. So you have to be a little careful from that regards also. So, but anyways, I've tried to simplify as much as possible. PCA supplies the posterior limb. Yeah, it can supply the posterior limb. So why, if you want to put a plus, you can put plus. I mean, but that's not important for me, basically. That's not a problem. So, but primary supply of the posterior limb is the middle cerebral artery only. That's what I need basically. But some amount of posterior limb can be supplied by the posterior cerebral artery also. Not a problem. If you want to put plus, or if you want, that's why I told you, this is not a extremely, like correct diagram, because no book will give you the same answer. Each and every book will have different answers depending on their particular type of data that they have collected. Anyways, so this diagram will look extremely complex by the time you look now, but if you have followed that from the beginning, it would have been much easier. So I think this is how the internal capsule is going to be getting supply from the lenticulostriate branches. I think that marks the completion of our anterior circulation stroke. I think that must be enough. So for anterior circulation stroke, do you understand? So all the entire anterior circulation and anterior circulation stroke, whatever is important, I've told you, whatever areas that are important. Other things, I don't know whether they will ask or not. These are the most important things. Okay, cool. So final take home point, MCA, if you have superior division infarct, you will get a Broca's aphasia. If you have inferior division infarct, you will get a Wernicke's aphasia. If you have lenticulostriate infarct, you will get no aphasia. That's all. This is the final take home point. If you forget everything, at least remember these 3 points. And as far as ACA territory is concerned, if you have a cortical infarct, your leg weakness and anything related to leg, incontinence, and the disinhibitory behavior. So that's going to be the most important. ICA, the one word that is important is the blindness. That's all. Nothing else is important there. Then let us move on to the posterior circulation stroke now. Yes, posterior circulation stroke now. We're going to the posterior circulation. As far as posterior circulation is concerned, there are 2-3 areas that you have to concentrate. First is the blood supply. Then how you unite with the brainstem, and how finally you will understand each and everything based on a very simple logic. That the posterior circulation stroke is, as far as the posterior circulation stroke is concerned. So first, let me draw 3 boxes. That's what I do generally. Let me take a little bit of time and let me draw in the bottom. So these 3 boxes are always going to be the brainstem structures. One is going to be the Probably I can talk about the medulla to start with. And you have the pons, and then we are going to have the midbrain. I need you guys to understand the basics first, then we'll go to the stroke syndromes, how to localize midbrain. So now, to tell the posterior circulation clearly, you start with the vertebral artery. So you have the two vertebral arteries. At the top of the medulla, they're going to unite together to form a single artery, that is the basilar artery, which is popularly called as a vertebrobasilar system. So this is the vertebral artery on either side, and which unite at the top of the medulla, at the middle third to upper third of the medulla. They're going to join together to form the basilar artery. So I can write this is the basilar artery. And basilar artery is going to unite together to produce two posterior cerebral arteries. So as simple as that. So they're going to form two PCS. So from this simple image, so from this only we are going to construct further. From the simple image, what you can understand is the fact that the elite artery of the medulla will be the vertebral artery. That's going to be the elite artery as far as the medulla is concerned. The major blood supply to the medulla is from the vertebral arteries only. Okay. Now, after understanding this, if you go to the pons, the elite artery of the pons is going to be the basilar artery. That's the most important artery of the pons. We know that as well. Then when you go to the midbrain, the most important artery of the midbrain is going to be the posterior cerebral artery. And that's all. So three arteries. From this simple image, what you can construct is the most important artery of the medulla is the vertebral artery, most important artery of the pons is the basilar artery, most important artery of the midbrain is the posterior cerebral artery. Now let us draw the minor arteries. Let me write the minor arteries in dotted lines. So these are the anterior spinal arteries, so I should not draw here. That's a big blunder basically. So the anterior spinal artery will be at the lower end of the medulla. So two anterior spinal arteries unite together to form a single anterior spinal artery. All right. And then in the medulla, you have a very important branch of the vertebral artery. These are called as posterior inferior cerebral artery. That is called as pica. That will be supplying the lateral aspect of the medulla. And of course, pons, basilar artery will provide a lot of perforating branches like this that supply the medial aspect of the pons. And of course, you have one important artery that supplies the lateral aspect of the pons, that is the anterior inferior cerebral artery. And you have labyrinthine artery and all those stuff. Purposefully, I'm avoiding that because I don't want to tell. Then you have two superior cerebellar arteries here. These are superior cerebellar arteries. And you had posterior inferior, anterior inferior, and superior. So three cerebral arteries are there. So two are inferior and one is superior. All right. Then finally, this posterior cerebral artery is going to have a communication with the anterior circulation. So this is a major communication with that of the anterior system. We know that. So through the internal carotid artery. These posterior communicating arteries are basically thought to be originating from the internal carotid artery, and they form the major communication of the anterior system with the posterior system. So this is the posterior communicating artery. And further, you can complete the anterior circulation very easily. So this ICA is going to give rise to MCA, which is going to further bifurcate into superior and inferior division. Again, MCA, that's going to bifurcate into superior and inferior division. And you have ACA, anterior cerebral artery. And of course, they are connected together by the anterior communicating artery. And you have anterior choroidal artery, and you have many lenticulostriate branches. From here, if you want to draw, you can draw the lenticulostriate branches also. And this is the recurrent artery of Hübner. And these are the lenticulostriate branches. If you want to complete the diagram, you can finish it off like this. So this is going to be the entire anterior as well as the posterior circulation as far as the circle of Willis is concerned. So now how can you understand? So if you see, the lateral portion of the medulla is primarily supplied by the pica, and the medial aspect of the medulla is primarily supplied by the anterior spinal artery. And the medial aspect of the pons is primarily supplied by the basilar artery, and the lateral aspect of the pons is primarily supplied by the anterior inferior cerebellar artery. and the entire midbrain is basically supplied by the posterior cerebral artery. So this is what you have to understand. And posterior cerebral artery gives a lot of perforating branches. Some small mini perforating branches will be there from the posterior cerebral artery that is going to supply the midbrain basically. And if you extend the posterior cerebral artery on one side, you will be noting that the posterior cerebral artery contains two zones. This area of the posterior cerebral artery that is located before the communication with the posterior communicating artery is what we refer to as a P1 segment. And beyond that communication, which means this area, what I'm talking about is this zone, this particular area, at the point where it meets with the posterior communicating artery, till that you will call it as a P1 segment, and beyond that you're going to call it as a P2 segment. And you know what this P2 segment is going to do? This P2 segment has a lot of purpose, but one important purpose of this P2 segment is to supply the cortex. Especially, you know, what are the cortical areas that they're going to supply? One is going to be the occipital cortex. In fact, the entire occipital cortex is basically supplied by the PCA only, and a part of temporal cortex, especially inferior part of the temporal cortex, is basically supplied by the PCA. And after that, you have P2, P3, and many divisions are there, but you can tell P1 and P2, that is more important. P1, because you need to understand P1 syndromes and P2 syndromes. And I can draw one more elite structure here. Basically, I can draw the thalamus here. So this is the thalamus. And one important branch that originates from the P1 segment and supplies the thalamus. P1 segment and supplies the thalamus. This is called as thalamoperforate branch. So I can write as TP here. So this is a thalamoperforate branch that is going to supply the thalamus, some part of the thalamus. And from the P2 segment also, I am having some arteries. These are called as thalamo-geniculate branches. And there are many other arteries that supply the thalamus. And for, you know, like for our understanding purposes, understanding the entire blood flow of the thalamus is completely out of the question. So, but you need to know that thalamoperforate is basically going to come from the P1 segment, and thalamo-geniculate branches typically come from the P2 segment. That's where they come from. So this is what we need really. First, whenever you talk about a brainstem stroke, or whenever you talk about a posterior circulation stroke, the first thing is, let us come from the distal most areas to the proximal most areas. Let us start with our occipital cortex. So whenever you have a problem in the posterior cerebral artery, first thing that can be affected is the occipital cortex. Whenever occipital cortex is affected, if it is affected on one side unilaterally, you will result in contralateral homonymous hemianopia. We know that. You're going to get contralateral homonymous hemianopia. But at the same time, you'll be getting something called a macular sparing. With macular sparing, that's what you will get. That is very typical of this occipital lobe involvement. Then after that, suppose if you are having a bilateral occipital cortex infarction, it's very rare, you don't get bilateral occipital cortex infarction. Suppose you get a bilateral occipital cortex infarctions due to bilateral PCA involvement, you will result in something called a cortical blindness. Cortical blindness, very characteristic. So this cortical blindness, previously they called it as something called a Anton syndrome. Anton syndrome. So you can understand this cortical blindness as a part of visual anosognosia. That's what happens. So we have seen a sensory anosognosia some time back where the patient is unaware of his own deficit. Similarly, what do you mean by visual anosognosia? Means the patient is unaware of his own blindness. That's what we call it as visual anosognosia. You know, whenever there is a bilateral PCA infarct causing bilateral occipital lobe infarcts, the patient loses macula, of course, because macula is supplied by both the PCA. That's why in unilateral it is not damaged. But when there is a bilateral PCA infarction, of course, you will result in damage to both the macula and the patient will be completely blind. That's what you expect. But in this particular syndrome called as Anton syndrome or cortical blindness, the patient will deny his or her own blindness. They will be completely denying again and again. They will tell that I am not blind. The denial of one's own blindness. It's not basically lying or denial. It is unawareness. So they don't really understand that they are blind. So this kind of a psychological issue is what we refer to as visual anosognosia. And that is a basic feature of cortical blindness, otherwise referred to as something called a Anton syndrome. Apart from that, dominant, I can write separately like this, that's better. So whenever you have a dominant occipital cortex involvement, so the patient may be having difficulty in reading. Whenever you have a difficulty reading, that is what we refer to as something called a alexia. Remember, but this will happen without agraphia. Why? Because the reading is a feature of the occipital cortex, all right. But writing is basically a feature of your parietal lobe. We have seen all that. That's a function of a dominant, what is that? Angular gyrus, which you have seen in the parietal lobe. So that's why this will result in a very peculiar form of a syndrome called as alexia without agraphia. The patient will be having difficulty in reading, but they won't have any difficulty in writing. So that's what we refer to as alexia without agraphia. Then they can have something called a achromatopsia. What do you mean by achromatopsia? Patient will see different colors. One color may look something like different. So they might not agree with the colors that you see as the colors what they see. That's what we refer to as achromatopsia. And they can have memory impairment. Why memory impairment? Because of the temporal lobe involvement. Memory impairment, that is because of temporal lobe involvement, because sometimes P2 syndromes can result in memory impairment also. Then apart from that, they can result in cognitive dysfunction. What are the problems in cognitive dysfunction? One is memory impairment, all right. They can develop aphasia. Aphasia. What kind of aphasia can anyone tell? So before that, I'll try and write cognitive separately. What is the type of aphasia they're going to get? Anyone? Cognitive. Of course, they will get memory impairment. Okay. Then not Wernicke's aphasia. Wernicke's is in the inferior, like branch of the middle cerebral artery. So they'll get aphasia. We have seen, something called a transcortical sensory aphasia. So that is the type of aphasia that you can get because of PCA infarcts. We know that these are P2 syndromes. And they can get something called a palinopsia. So what do you mean by palinopsia? I mean, this is very commonly seen in the movies. For example, the heroine would have gone from that particular place, but still the hero will be seeing that as if the heroine is there standing in the same place. I mean, that is palinopsia basically. Like even after removal of the stimulus, persistently you are seeing the stimulus in the same place. Like that is palinopsia basically. Not all these are temporal, and certain things are temporal. For example, memory is temporal, aphasia is predominantly due to the temporal lobe, and palinopsia basically is occipital lobe again. So achromatopsia, alexia, palinopsia are basically temporal, occipital lobe involvements. The memory and aphasia are basically temporal functions. And in the temporal lobe, the most important that is very commonly asked in exams is the fact that you get that, what is that? Prosopagnosia, which I've discussed already. Prosopagnosia. Prosopagnosia, you know what is that? It will be usually due to right PCA infarcts. That's a non-dominant inferior part of the temporal lobe infarcts near the lingual gyrus. So that is where you're going to get prosopagnosia. We know that. So all these things, whatever I've described till now, whatever I've described are basically called as P2 syndromes, which means they are not P1. They can happen only if it's a proximal PCA infarct or maybe in the P2 segment. So that's why they are called as basically P2 syndromes. And then you have P1 syndromes also. So one of the important P1 syndrome is this occlusion of a thalamoperforate artery. Thalamoperforate artery occlusion. So that is where you get the P1 syndrome. There are a lot of other P1 syndromes also, but let us first start with the thalamoperforate branch. Now we have covered the P2 segment. Now we are moving on to the P1 segment. So now I'm talking about the P1, thalamoperforate occlusion. So thalamoperforate occlusion will result typically in a form of syndrome called as Digerin-Rossi syndrome. That's a syndrome that you will get due to occlusion of the thalamoperforate branch, which basically supplies the thalamus. Vision abnormality is present P2 syndrome. Yes, vision abnormality can be present in your MC hereditary infarct also. In posterior cerebral artery infarction, if vision abnormality is present, it is very likely to be a P2 syndrome only. Yes, this is what we refer to as something called a thalamoperforate artery occlusion called as Digerin-Rossi syndrome. Remember, here I've drawn the usual anatomy. What is the usual anatomy? I've drawn two thalamoperforate arteries, and that's how the usual anatomy is. But sometimes what can happen is these two thalamoperforate arteries can unite together to form a single thalamoperforate artery, or you can have only a single thalamoperforate artery that is supplying both the thalamus. So which means usually in these kind of circumstances where you get a single thalamoperforate artery instead of two thalamoperforate arteries, that is where your degenerate syndrome is extremely common. So which means usually when there is two thalamoperforate branches, degenerate syndrome is not quite common. But you have a single thalamoperforate branch, you will get a degenerate syndrome. That is where it's going to be extremely common. So as far as degenerate syndrome is concerned, you can get sensory loss initially. Initially, the patient will be suffering from a sensory loss. That's how they start with. I mean, they can be a full body sensory loss, or they can be a hemisensory loss also, depending on the extent of involvement of the thalamus. So post this sensory loss, they're going to result in within few days to weeks. After a few days to weeks, they will result in development of severe burning and agonizing pain. They'll have a burning and agonizing pain. Within few days to weeks, this sensory loss will be getting transformed into pain. So this is basically degenerate syndrome. Treatment is very difficult because thalamus is a relay center, and this is like confusion of the thalamus where they are perceiving sensation differently and they are projecting the cortex in a very different way. That's why they're getting this burning and kind of a painful scenario. Yes, you don't do ectomy, but basically not extreme procedures, but you basically tend to treat with neurologic drugs like gabapentin, pregabalin. So that's the usual treatment we give. They usually respond in a decent way. It's not like very bad response and all. So now we have discussed about the PCA. Now, after knowing all these things, we are moving to the the brainstem strokes. That's what we are going to move towards. So let us step by step construct the brainstem strokes. First of all, you suspect a posterior circulation stroke. You suspect a posterior circulation stroke. You know how will you suspect a posterior circulation stroke? Already you have the criteria when you will suspect a posterior circulation stroke. In the event of a posterior circulation stroke, next thing what you have to do is you see whether the patient is having primary visual issues, or I can write predominantly visual issues. Predominantly visual symptoms, or patients having any evidence of other cortical symptoms and signs, like your memory loss, amnesia is a cortical symptom and sign, or if I'm prosopagnosia, cortical symptom and sign. So we are talking about that. So if you have predominantly cortical symptom and sign, and predominant visual symptoms are there like homonymous hemianopia, then usually that goes towards a PCA territory infarct very commonly. So that's where you're going to think about. It's a cortical stroke. Cortical stroke. PCA means we are predominantly talking about a P2 syndrome, not a P1 syndrome. So if no means I'm basically talking about a subcortical stroke. Now it's not a cortical stroke anymore. So I'm basically dealing now with a subcortical stroke, likely subcortical stroke. Now in this scenario, so if the patient is presenting with predominant pain and sensory features, predominant pain and altered kind of sensation, altered, or I can write abnormal sensation. More than altered sensation, the abnormal sensation will be a right word. Predominant pain, abnormal and unpleasant sensations, not basically sensory loss, abnormal, unpleasant sensations. We are basically dealing with a P1 PCA territory, in fact, that is producing a degenerate syndrome. Or simply I can tell the patient is having a thalamic stroke, likely in this situation. I cannot confirm anything based on clinical examination. I can suspect that this is the probable area. Now, if the patient is not having any predominant pain, so no painful scenario or no abnormal pain, sensations that are present in the patient, then in this setting, I'll be asking a question if it's a brainstem stroke. So brainstem stroke is also basically a subcortical stroke only, it's not a cortical stroke. Now this is the question I'm going to ask. That's a brainstem stroke. So to know whether it's a brainstem stroke or not, you need to know certain things basically to start with. So for that, we need to really understand certain other aspects, which will come back to that. Now, I can talk about the brainstem as a whole. So let me put a shape. So I can draw the brainstem as a whole like this. Now, yes, crossed features will be there. I'm not telling no, but more importantly, it's important to understand what are the structures that pass through the brainstem in a very simple way. We are not going to discuss about the cut sections because cut sections are going to really help you in any way. So there is something called 4 S structures that are present on the side, and there is something called 4 M structures that are present on the medial side, that is, they are present on the middle. And apart from that, you have some 4 cranial nerves that are basically midline cranial nerves. And apart from that, you have 4 cranial nerves above the pons, below the pons, and in the pons. So let me tell the rule number 1. To start with, we can go here to our old diagram. So the rule number 1 states, it's a very simple rule. You're going to have 4 cranial nerves above the pons, 4 cranial nerves in the pons, and 4 cranial nerves below the pons, which means there are 12 pairs of cranial nerves. We know that 4 above the pons, 4 in the pons, and 4 below the pons. You know what are they? You will be able to easily tell that. The 4 cranial nerves above the pons are going to be 1, 2, 3, and 4. In that I can write 3 and 4 in the midbrain. 1 and 2 are above the midbrain, so I'm not going to write 1 and 2. These are completely different special senses nerves. So 3 and 4 I can write here. Then the remaining 4 cranial nerves are in the pons. That is 5, 6, 7, 8 are in the pons. And you have the remaining cranial nerves, that is 9, 10, 11, and 12 are present below the pons. That is, it is present in the medulla. So rule number 1 is fine. You have 4 rules. The first rule I have told you, 4 in the pons, 4 above the pons, and 4 below the pons. That's all. So this is how your understanding is. Then in that, the 10 cranial nerves I have told, you are going to tell, and you are going, I mean, there is a clue for that. 4 cranial nerves are basically in the midline or in the middle. So what you're going to tell is you are going to pick up this cranial nerves and take the numbers that divide the number 12 equally without any decimal points, which means I'm talking about a rational number. I mean, I don't know. What do you mean by rational number in mathematics? So which means what are the numbers that divide number 12 as a rational number without any decimals? You should not get any decimal point, but you should give some numbers that can divide the number 12. What are the numbers that can divide number 12 equally without any decimal points? Okay, many people are giving many answers. You have 1, you have 2, 2 into 6 is 12, then 3 into 4 is 12, then you have 4 into 3 is 12, then you have 6 into 12, 6 into 2 is 12, and 12 into 1 is 12, basically. So you have 1, 2, 3, 4, 6, and 12. So these are the numbers. And of course, in this, I'm going to exclude this 1 and 2 because I don't want it, because it's above the brainstem. So what are the remaining that is located? I mean, what are the remaining that is left? What are the remaining that is left if I exclude 1 and 2? 3, 4, 6, and 12. So these are the 4 cranial nerves that is left. So what I can really tell is, so these 3, 4, 6, and 12 are basically midline cranial nerves. So I can write this 3, 4, 6, and 12 are basically midline cranial nerves. In that I can write 3 and 6, I mean 3, 6, and 12 here. And I'm just going to mention that cranial number 4 on the other side, because, you know, as per anatomy, this is the only cranial nerve that originates from the dorsal aspect of the brainstem. That's why I'm writing in the extreme direction on the other side. But as far as I know, this 3, 4, 6, and 12 are the midline cranial nerves. And incidentally, if you take this 3, 4, 6, and 12, they are also the pure motor cranial nerves, if you remember, including 11. 11 is also pure motor cranial nerve only. But apart from that, the most important, 11 is always not really considered as a cranial nerve, unless and until you go for exams. But more importantly, this 3, 4, 6, 12 are very important. These are not only midline, these are not only present in the middle, they are also the motor cranial nerves, 3, 4, 6, and 12. All right, fine. So similarly, I told you there are 4 S structures that are going to be present on the side. But before that, telling the 4 S structures, tell me the remaining cranial nerves that will be present on the side. So already I told you 3, 4, 6, 12 is in the midline. So what are the remaining cranial nerves that will be present on the side? So you have 5, you have 7, you have 8, you have 9, you have 10, and you have 11. So 5, 7, 8, 9, 10, 11. So these are the cranial nerves that are basically going to originate from the side of the brainstem, not from the middle of the brainstem. So 3, 4, 6, 12 midline, 5, 7, 8, 9, 10, 11 on the side. 3, 4, 6, 12 pure motor, and including 11. 11 is also pure motor, but remaining all the other cranial nerves are basically mixed cranial nerves. They have sensory as well as motor function. And fine. So you have this kind of distribution. Then I told you there are 4 S structures that are present on the side. So what are the 4 S structures that are present on the side? The first S is going to be the spinothalamic tract. I can draw here the spinothalamic tract just to start with. Spinothalamic tract is present on the side. And the second S I can talk about is the sympathetics. I think we have discussed already in the Horner syndrome in the form of lateral reticular formation. And they are basically present on the side only. We know that. And apart from that, you have an important nucleus called as spinal nucleus of trigeminal nerve. Spinal nucleus of trigeminal nerve. This is basically present on the side only. I'll tell you why this spinal nucleus of trigeminal nerve is there and why that is important. And apart from that, you have another pathway that is called as spinocerebellar tract. So that is going to form something called a cerebellar peduncle. So I'm writing a wrong spelling, but still that will be helping you. Cerebellar peduncle. They are basically extension of the spinocerebellar tract that is coming from the spinal cord. So that form the cerebellar peduncle. And you have 3 cerebellar peduncles. One is the superior, middle, and the inferior. You know, superior is present in the midbrain, middle is present in the pons, and inferior cerebellar peduncle is present in the medulla. You know that. So these are the 4 S structures that are present on the side. So cerebellar peduncle, sympathetics, spinothalamic tract, and of course you have the spinal nucleus of the trigeminal nerve. Why this understanding is important? Because whenever you have a lateral brainstem stroke, like lateral medullary syndrome or lateral pontine syndrome, these are the structures that are going to be affected predominantly. So in any lateral brainstem syndrome, even though there are many other overlapping syndromes out there, vascular territory is never the same for all the patients. But as a whole, you can tell that in any lateral brainstem syndrome, these are the structures that will be typically affected, including the lateral cranial nerves. So more than drawing like this, I can draw something like this. So these are the cranial nerves that are going to be typically affected in a lateral brainstem syndrome. Fine. Apart from that, as I told you, there are 4 M structures that are present on the medial side or in the middle. So these structures are going to be number 1, your motor pathway. So I can draw like this. The first one is the motor pathway. First M stands for motor. So this motor pathway is nothing but corticospinal tract, which means they are supplying the limbs. But at the lower end of the medulla, they're going to cross to the opposite side. That's fine. But right now, these are uncrossed corticospinal tract that is present in the brainstem. And it's called by different names. For example, in the midbrain, it will be called as crus cerebri. In the medulla, it is called as pyramidal tract. And in the pons, you won't have any name for that because they'll be spread out somewhere. But in the medulla, it will be called as pyramidal tract, and in the midbrain, it will be called as crus cerebri. And at the same time, this midline cranial nerves. So these form the second M. This 3, 6, 12, and 4. This 3, 4, 6, 12. These are basically the midline or the medial cranial nerves. So they form the second M that you're talking about. And there's another M. There's a third M that is contributed by something called a medial lemniscus. Medial lemniscus. I'll tell you what do you mean by medial lemniscus. Then the 4th M is there. That is an exclusive structure of the pons. It's not present anywhere else. It's present only in the pons. You can imagine like that. That's called an MLF. That is called a medial longitudinal fasciculus. MLF. So now you can understand that in many medial strokes and the common strokes that you're going to encounter in the medial brainstem stroke, these are the structures that are going to be affected, basically. Which means in medial strokes or medial brainstem strokes and medial syndromes, these are the usual structures that will be affected. So we have completed the rule of 4. In one particular diagram, we have completed the rule of 4. The first rule is 4 cranial nerves above the pons, 4 in the pons, 4 below the pons. And second rule is 4 cranial nerves are midline cranial nerves 3, 4, 6, and 12. We know how we derive that. And 4S structures are present on the side. Yes, it's given by Peter Gates. And you know, like Peter Gates basically gave this in 2003 in NEJM article. And he was a pre-final year student at that time. That's the most interesting thing. And 4 S structures are present on the side, and 4 EM structures are present on the middle. Fine. So now there are some new things we have introduced here. So let us finish off that also. What are the new things we have introduced? So one thing that we have introduced is something called a spinocerebellar tract is what we have introduced. And we have the medial lemniscus, which I have introduced as a new. And spinal nucleus of trigeminal nerve is also something that is new that is introduced. And MLF is also something new that is introduced. So, I mean, whenever we study new things, let us understand about that simultaneously. That's the best way of learning. So first, the spinothalamic tract. So what happens to the spinothalamic tract? So it's going to carry the pain and temperature. But to start with, you can understand that's going to carry the pain and temperature sensations from the skin. Okay, fine. So let us, I mean, this is a conceptual diagram only. So this is a spinal canal. And let us assume this is the posterior area and this is the anterior area. And as far as the spinothalamic tract is concerned, you're going to get the first order neurons, which have the cell bodies in the dorsal root ganglia. You have something called dorsal root ganglia that is present near the spinal cord itself. And these first order neuron cell bodies are basically present in the dorsal root ganglion only. And these are the fibers that are carrying the pain and temperature from the skin, from the limbs, trunk, and everywhere. And they're going to synapse here in the spinal cord in an area. What is that area called as? I mean, maybe you can draw here. What is that area? Anyone? Yes, that is called the substantia gelatinosa of Rolando. Okay, let me draw here. So this area is what we refer to as substantia gelatinosa of Rolando. From here, you're going to have the second order neurons that cross to the opposite side in front of the central canal. And they're going to rise up as the lateral spinothalamic tract. You have two types of spinothalamic tract. One is called the anterior and second is a lateral spinothalamic tract. But we are talking about a lateral spinothalamic tract for that perspective. So this is a lateral STT, that's a lateral spinothalamic tract that's basically ascending up along the lateral portions of the spinal cord. And while ascending up, they go to the brainstem. And in the brainstem, they essentially don't have any synapse there. So we can talk, this is the brainstem. And even in the brainstem, they ascend in the lateral portions just like that. And they're going to synapse in the thalamus now. In the thalamus, there is another area called as VPL nucleus, that is ventral posterior lateral nucleus, we know that. And from the VPL nucleus, you get the sensory fibers. These are the third order neurons. So spinothalamic tract is basically the second order neuron. And from the VPL nucleus, you're going to get the third order neurons, which are going to pass through the posterior limb of the internal capsule. And from there, you have something called a superior thalamic radiation. And this superior thalamic radiation is going to further fan out as something called a sensory radiation. And they're going to enter the primary somatosensory cortex, SSC. And these are the third order neurons that we're talking about. So this is quite simple and cool, isn't it? That's all. So which means they're basically carrying the pain and temperature. That's the first point that you need to know. And apart from that, the second order neurons is what we basically call it as something called a spinothalamic tract in the first place. These are nothing but the second order neurons in the pathway. So now what is important to understand is whenever I get a lesion in the spinothalamic tract, anywhere from here in the brainstem or in the spinal cord or probably within the particular section or whatever, wherever I get a lesion of the STT, where will be the lesion? Contralateral or ipsilateral? That's the most important point to understand. Where will be the lesion? On the contralateral side, I mean, if the lesion is there on one side, you will have effects on the contralateral side or ipsilateral side. Effects, of course, will be on the contralateral side because it has crossed at the level of the spinal cord itself. At the level of that particular segment itself, it has crossed. So whenever you get a spinothalamic tract lesion, irrespective of the site, it can be in the brainstem or above the brainstem or below the brainstem, you'll always result in contralateral loss of pain and temperature. Remember, spinothalamic tract is basically carrying the pain and temperature sensation from the limbs, from the body. Who's carrying the pain and temperature from the face? It must be the trigeminal nerve. We know that. And you can remember trigeminal nerve has multiple nucleus. You have mesencephalic nucleus of trigeminal nerve, dorsal nucleus of trigeminal nerve. Then we have principal nucleus of trigeminal nerve. In that we have one more nucleus called spinal nucleus of trigeminal nerve. So you have to imagine the spinal nucleus of trigeminal nerve like spinothalamic tract of the face. For the face, you don't have a separate spinothalamic tract. It's the trigeminal nerve only. So the spinal nucleus of trigeminal nerve is the one that carries the pain and temperature sensation from the face. For the body, you have spinothalamic tract, but for the face, you have spinal nucleus of trigeminal nerve. But one thing about the trigeminal nerve is this trigeminal nucleus are fibers they're going to receive from the ipsilateral side. And like spinothalamic tract, they cross in the brainstem to the opposite side. But the spinothalamic tract, on the other hand, has crossed in the spinal cord level itself. Which means what is important is whenever you put a spinothalamic tract lesion, you will get problems on the other side only. Whenever you put lesions in the spinal nucleus of the trigeminal nerve, you are going to result in problems on the ipsilateral side only, as far as trigeminal nerve is concerned. So these are the two important differences that you need to know, even though they are both same. But if you put a lesion in the brainstem, if you put a lesion in the spinothalamic tract in the brainstem, you will result in contralateral problem because you are affecting the uncrossed fibers of spinal nucleus of trigeminal nerve. If you put a lesion of the spinal nucleus of trigeminal nerve, you will get result only in ipsilateral loss of pain and temperature. That is the reason why whenever you affect the brainstem, you will result in that kind of crossed sensory loss, which we'll be discussing after some time. So spinal nucleus of trigeminal involvement, ipsilateral loss of pain and temperature on the face. Whenever you involve the spinothalamic tract, anywhere from the brainstem above or below the brainstem, you will be resulting only in contralateral loss of pain and temperature, which is again fairly important to understand. And you have these are all the features of lateral spinothalamic tract, which is the most important. You have anterior spinothalamic tract also. Basically, anterior spinothalamic tract carries your more older evolutionary sensations, like for example, itching, tickling, crude touch. So these are the things that will be carried by the anterior spinothalamic tract. That is not really important for us. The lateral spinothalamic tract and the carrying of pain and temperature is going to be the really most important entity. And then now you need to know the medial lemniscus. So there is something else that is coming in the medial side, isn't it? That is medial lemniscus. So what do you mean by medial lemniscus? Let us see. As far as the medial lemniscus is concerned, it is just continuation of the posterior column in the brainstem. That's all. But let us see the pathway. Let us see the pathway here. So for understanding case, I'm writing this is posterior and this is anterior. And let me draw the first order neurons. These are first order neurons. And these are the ones that are carrying the posterior column sensations. Let me come back to the posterior column sensations in some time. These are the basically posterior column sensations. And these are the dorsal root ganglion. Same, the cell bodies of these first order neurons we are talking about will be present in the dorsal root ganglion only. And unlike the spinothalamic tract, they ascend up straight away. They don't have any communication in the spinal cord, which means they don't have any specific nuclear communication in the spinal cord. They just ascend up. And unlike spinothalamic tract, they're going to synapse in the brainstem. So I can write, they're going to synapse in the brainstem. So where in the brainstem? They're going to synapse in the lower part of the medulla. The very lower part of the medulla itself, they will synapse. You have two nucleus, but let me call that later on. So let me put in the orange. So there is a nucleus here. You have two nucleus, in fact, nucleus cuneatus and nucleus gracilis. Let me talk about that later on. So they're going to synapse in the lower aspect of the medulla itself that I have put in the lower aspect. So then they cross here in the lower part of the medulla itself, and they ascend on the medial side of the brainstem, on the medial aspect of the brainstem. And these second order neurons is what we refer to as something called a medial lemniscus. These are basically second order neurons, medial lemniscus, and they're going to synapse, of course, in the thalamus, the same area, that is ventral posterior lateral nucleus of the thalamus, because thalamus is a relay center for sensations. From here, they are going to radiate to the somatosensory cortex, of course, and to the same posterior limb of the internal capsule as superior thalamic radiation. And through this kind of fanning out process, this is basically the sensory radiation, like spinothalamic tract, and these are the third order neurons we are talking about, and they're going to synapse in the primary somatosensory cortex, in the postcentral gyrus. That's how they're going to synapse with. So this is the pathway for posterior column sensations. So now it will be a little different. For example, if you damage the posterior column sensation in the spinal cord, you're going to typically result in something called ipsilateral problems, which means same side only will result in problems. If you damage the medial lemniscus, on the other hand, you're going to result in contralateral problems. So in the spinal cord, they'll be called as posterior column. As soon as they go into the brainstem, they'll be called by a different name that's called a medial lemniscus. So this is what we called as a posterior column medial lemniscus pathway. So medial lemniscus problems will usually result in contralateral issues, whereas posterior column issues means it's in the spinal cord, which means it's going to result in problems ipsilaterally only. And you have two group of tracks are there in the posterior column. For example, if you see the arrangement of these tracks, there will be two groups of tracks that will be arranged. Posterior column itself, in the posterior, I mean, that's why, because they go along the posterior side of the spinal cord, they're called as posterior column. And those that are present on the medial side, we called as nucleus gracilis. And those that are present on the lateral aspect, we called as, fasciculus gracilis. And those that are present on the lateral aspect is what we refer to as fasciculus cuneatus. So you have two tracks are there, separate tracks, fasciculus gracilis and fasciculus cuneatus. And gracilis carries fibers from the legs, sensations from the legs, and cuneatus carries sensations from the arms, that is the upper limb predominantly. Usually I remember by mnemonic called graceful legs. So legs of many heroines will be very graceful. So that's why we remember as graceful legs. So gracilis carries from the legs. And you have nucleus gracilis and nucleus cuneatus separately in the lower part of the medulla. Even though to avoid confusion, I've drawn only one single nucleus. Nucleus gracilis and nucleus cuneatus is also there. So now you know. So where if you have the problem, where you're going to get the issue. More importantly, as far as the posterior column sensations are concerned, you have certain important sensations. You have to tell in a very orderly way. Usually I tell in that one. Yes, gracilis is also lower limb muscle. You remember like that. Okay. I remember I'm a perverted guy, isn't it? So I remember like graceful legs. Indra is remembering us. Gracilis is a lower limb muscle. Cool. I'm feeling ashamed, Indra. Sorry. Posterior column sensations. So what about the posterior column sensations? What are the posterior column sensations? You're going to tell in an order. So what order you are going to tell? This is actually, no, you should not tell in that order, Sankhya. I think Riju will understand. So I'm going to tell to Riju what order you need to tell. The first thing that you need to tell is fine touch. Okay. You understand. So how you're going to touch? Fine touch. That's the first thing that you have to tell. After fine touch, what you will do? I mean, the sense, what sensation you need to understand is what are the other sensations are there? Vibration. Okay. Once you have finished your fine touch, then you move on to vibration. So once you have finished vibration, then you end up in a position. Or maybe you can tell in a different order also. First, after fine touch, you go for pressure, isn't it? So you don't directly go for vibration. First, you give some pressure. So fine touch, pressure, then you go for vibration, then you do some vibration. Then finally you achieve your position. So you should tell in an order. So don't tell this like this to the lady examiner. Madam, fine touch, pressure, vibration, position. So yes, definitely you are failed. I think Rich is going to tell like that only to the examiner. Especially if a lady examiner is going to come, he's going to tell like fine touch, pressure, madam, vibration, madam, then position, madam. Nilasish is going to tell Fakka. Okay. So this is how you remember the posterior column sensation. And this, what kind of position is this? I mean, what kind of position? We are going to tell a conscious position. I mean, of course, you consciously maintain the position. That is the function of the posterior column. So there is something called unconscious proprioception also. Unconscious proprioception is basically going to come from the spinocerebellar tract. Cerebellum is the center for unconscious position, not for the conscious position. Correct? And even joint position is basically from the posterior column only. Joint position is also basically from the posterior column only, where it is very important again. And plus, more importantly, everyone forgets that all the cortical sensations are basically carried by the posterior column only. Whatever that cortical sensation we call, all the things are basically carried by the posterior column only. And what are the cortical sensations? So you have something called tactile localization. Tactile localization. What do you mean by tactile localization? Even if mosquito bites in some unwanted place, even if you don't every time see the mosquito, you correctly go and hit that. So that is tactile localization. You know where your body parts are. Not definitely, you don't know where your girlfriend's body parts are, but you know definitely where your body parts are and you can exactly localize. So that is what we refer to as tactile localization. Then we have something called 2-point discrimination, right? So what do you mean by 2-point discrimination? So ability to identify 2 points as separate in a particular area is 2-point discrimination. For example, nature knows what are the areas where you need to discriminate better. That is why it has kept highest 2-point discrimination, and the lowest distance is present in the fingers. Very important, isn't it? That finger movements and all. Then you have the lips. Nature itself knows which areas are very important in life. And tongue. These are the areas where your 2-point discrimination will be the best. And your distance between the 2 points to identify them as separate will be the least. Clear? And nature again knows what are the areas that are not necessarily that important, where just crude understanding is enough. Like for example, your back, your buttocks, your thighs, like crude understanding is enough regarding those sides. So there's not much discrimination required basically. Then you have next thing that is called as astereognosis. I mean, not astereognosis, stereognosis. Stereognosis. What do you mean by stereognosis? I will ask Riju one question. Riju, if you close your eyes and if I give you some object in your hand, will you be able to touch and identify it? What is that object? Yes, see, immediately he's telling yes. Whatever object I give, by closing his eyes itself, is going to touch that and is going to find it out. So that is stereognosis, because he's expert in that. That's why. So if you're not able to identify that, that is what we call as something called a astereognosis. Then after that, we have something called barognosis. So what do you mean by barognosis? B-A-R-O-G-N-O-S-A-S. And what I'm going to do is, again, I'm going to call Riju for help. So I'm going to give 2 objects in Riju's hands. And I'm asking him to lift both the objects and find out which is heavier. And Riju is able to tell which object is heavier and which is lighter. So yes, that is what we call as barognosis. Ability to identify 2 objects as which is heavier by lifting it and seeing, but within physiological limits. You cannot lift 1 ton in both the hands and say which is heavier. So within physiological limits is what we refer to as barognosis. And then we have another one. What is that? Graphesthesia. You know what do you mean by graphesthesia, isn't it? I mean, you should not put sign in the hand, Amitabh Bachchan sign and all. You should put some simple objects like plus, minus, circle. If you draw something like that, you will be able to tell what they are approximately drawing. So that is what we refer to as graphesthesia. And finally, we have something called a tactile extinction. So loss of extinction is what we refer to as neglect. Hope none of your PGs are attending the lecture. Okay. So you're going to do all this kind of nonsense to them. That's why you're telling, hope none of my PGs are attending this lecture. Okay. I will tell those PGs that there will be a guy called Riju who will come and tell all these things to you. And he's the one who taught me. That's what I'm going to tell them. So there is something called tactile extinction. So what do you mean by tactile extinction? We discussed already. So ability to identify simultaneous stimulus from both the sides as simultaneous stimulus is what we refer to as tactile distinction. Remember, same place identifying two separate stimulus as separate is 2-point discrimination. Both sides simultaneous stimulus identifying that is extinction. Loss of extinction is what we refer to as neglect. So these are the cortical syncytium. All these cortical syncytiums are basically carried by the posterior column only. And this is basically the posterior column medial lemniscus pathway, PCML pathway. So now based on this, you can understand cortical syncytiums are better at palms and lips, and they are tested at the palms. Yes, basically they are better at the palms and lips only. And palms only we test usually. You cannot test at the lips, and that's not fair for that particular guy or girl also. So what about the brainstem stroke? So as we move on to the brainstem stroke, so now the question we have asked is still the same. We have not attempted to answer that question. That is it a brainstem stroke? That's why we're going to ask that question. So now our answer is very simple. So I'm going to see whether is there any evidence of cross deletion. Evidence of cross deletion is there. So if yes, likely to be a brainstem stroke. Brainstem stroke likely. If no, actually it's unlikely to have a brainstem stroke. Even though I'm telling only unlikely because you cannot confirm, you cannot rule out, but still as a clinical decision, I will tell my brainstem stroke is, or any brainstem lesion is unlikely. So in the cross lesion, I am seeing whether predominant sensory involvement or predominantly motor involvement. Motor involvement. If it's a predominantly sensory involvement, I'm going to think about a lateral brainstem lesion. And if it's a predominantly motor involvement, I'm going to think about a medial brainstem lesion. Or you can call it as a non-lateral lesion also, likely to be a medial lesion. That's all. So as far as the lateral lesion is concerned, so what will be the idea behind that? So if I draw a person like this, so this is the same exact diagram I used in my MD also. I don't know how they passed to me, but still this is the same diagram I used in my MD. Okay. So now I'm seeing something like this. Because I told you it's a predominant sensory involvement, I'm talking about a pain and temperature here. If I have a cross lesion, in the sense like I'm having loss of pain and temperature on one side of the face and loss of pain and temperature on the other side of the body. Remember, I'm not using ipsilateral and contralateral yet. I'm using on one side and I'm using on the other side. That's what I'm using. So which means this is a pain and temperature loss pattern. I'm having a pain and temperature loss. In the face, I'm having on one side, but in the body, I'm having on the other side. So this is what we refer to as something called a crossed lesion. So this is what we call as a cross lesion, and this is very characteristic of a brainstem lesion. If it is there, I can be very sure that it's a brainstem lesion only. But there can be other evidence of that this is a lateral stroke. For example, these patients may have additional cerebellar involvement, and these patients may have sympathetic involvement, and they can result in Horner syndrome. And you know, this Horner syndrome will be central Horner syndrome. It's very clear because it's a brainstem stroke. It's a first order neuron involvement, so it will be central. There will be anhidrosis in these patients. And apart from that, there is this kind of cross sensory loss is also there. So these are the other features. So if you want to tell which is ipsilateral and which is contralateral, it's quite simple, which means, as I told you, always face will be ipsilateral because it is why face is involved, because that is due to involvement of the spinal nucleus of the trigeminal nerve. We have seen just some time back. So it is like a spinothalamic tract for the face. If it is involved, there will be ipsilateral loss of pain and temperature in the face. So body will be on the contralateral side, we know, because that is due to spinothalamic tract involvement. And cerebellum, always ipsilateral. Horner syndrome, always ipsilateral, which means the only one thing that is contralateral to the side of the lesion is the body sensory loss. So see where is the body sensory loss, and that will be the contralateral side, and opposite to that will be the side of the lesion. That's the easy thing to understand. So now I need to know where is my lesion basically. So now I have this cranial nerves, whether the lesion can be in the medulla or lesion can be in the pons. So now I need to know which cranial nerve is affected. That will give you a very good clue. For example, lesion can be in the medulla. If the lesion is going to be the medulla, my 9th and 10th cranial nerves are going to be predominantly affected, even though there are other lateral cranial nerves also, because we are thinking of a lateral lesion. Lateral lesion means my lateral cranial nerves are the ones that will be usually affected. If the lateral cranial nerves are the ones that are usually affected, which cranial nerve will be affected? If 9 and 10 is involved, means I'm likely dealing with a medullary lesion. That's all. If predominantly my 9th and 10th, 11 can be involved. I'm telling plus or minus 11. I am not worried about that right now. If 9 and 10 is predominantly involved, then I'm talking about a medullary lesion, because these are basically medullary lateral cranial nerves. So in this setting, I'm going to talk about a lateral medullary syndrome. Lateral medullary syndrome. So what are the features of 9 and 10th cranial nerve palsy? Of course, these are the cranial nerves. These are, remember, LM and 9th and 10th cranial nerves, because it's a posterior circulation stroke and they're basically involving the nerves. Whenever you damage the nerves, that is an element lesion. So in the nucleus or the nerves, it is element. Above the nucleus, it is human. We know that. So this is an element cranial nerve palsy. So when you're going to affect element means you're going to involve the same side, you'll be having dysphagia, because these are the cranial nerves that are going to be involved in swallowing. These are the cranial nerves that are involved in the movement of palate, the posterior part of the pharynx, and the early part of the esophagus. All these things are going to be managed by the 9th and 10th cranial nerve only. So dysphagia is a very, very important feature. And vagus also supplies the vocal cords, so you'll be resulting in abnormal voice production in the form of dysphonia. And at the same time, these patients will involve palate, because the palate is not contracting properly. They will have a type of dysarthria called as palatal type of dysarthria, where letters like K cannot be pronounced properly by these fellows. That's a typical sign of a palatal dysarthria. K, you need palate for that. In Tamil, we call Ka. So that's a palate. Clear? So you cannot pronounce that kind of K related. They will pronounce as H. You cannot pronounce Ka or K because palate is not contracting, or it will be abnormal. So that's a type of dysarthria. It's not an aphasia, it's a type of dysarthria. Aphasia means only if you involve Broca's, Wernicke's, those areas will get aphasia. It's a subcortical lesion, and same time it's motor problem. Dysarthria, typically. Palatal type of dysarthria. Then remember, but dysarthria, you should be a little careful, because this dysarthria should not be confused with cerebellar type of dysarthria, because cerebellum is also subcortical lesion. So that can result in type of dysarthria called as scanning type of dysarthria, or otherwise called as staccato type of speech. So you should not confuse with that. So they can have either type of dysarthria. So that's one point to be noted. And apart from that, they will have absent gag reflex, because this is an element lesion. So reflex will be lost. So they'll be having absent gag reflex on the ipsilateral side, because it's an element palsy. So on the same side, they will have loss of gag reflex. And at the same time, there will be uvular deviation. Deviation of uvula will be there. Deviation of uvula to the healthy side, that is towards the contralateral side. That's what happens here. Deviation of uvula to the contralateral side. So these are basically the features of a lateral medullary syndrome, otherwise referred to as Wallenberg syndrome. So if somebody asks you what are the features of lateral medullary syndrome, I'll tell ipsilateral loss of pain and temperature on the face, and contralateral loss of pain and temperature in the body, and ipsilateral cerebellar symptoms, and ipsilateral Horner syndrome, and ipsilateral loss of gag reflex, and deviation of uvula to the contralateral side, and I'll be having dysphagia, dysphonia, and dysarthria. That's all. This is what the constellation of features that you will get in Wallenberg syndrome. In that, one new thing that we have not yet learned here is the cerebellar symptoms. That is something which you have not learned yet. So what are the cerebellar issues you will be getting? Cerebellar problems mostly will be ipsilateral, with a very few exceptions like Claude syndrome where it can be contralateral. But apart from that, cerebellar problems usually will be ipsilateral only, most of the times in clinical practice. So what are the cerebellar problems? Hypotonia. Number one, they should not be confused with hemiparesis. I'm not talking about weakness of the limbs. It's only loss of tone, hypotonia. Then you can result in ataxia. Both, it can be a limb ataxia or a trunk ataxia. Both can happen. And I can get nystagmus. Different types of nystagmus. It's a central type of nystagmus. In body, there is hemiplegia or sensory loss. I clearly told you it is sensory involvement. We are not talking about hemiparesis. I'll come back to that. That's a very important blunder that you're going to make if you tell it's hemiparesis. So nystagmus, then I can get a type of knee jerk called pendular knee jerk. And patients will be having significant incoordination because cerebellum is important for coordination. So incoordination in the sense they will be, especially that loss of, that poor coordination with repetitive movements. You know how to check this repetitive movements, isn't it? Repetitive movements like this dysdiadochokinesia, then finger nose test, then heel shin knee test where you do in the legs. I studied all these things in the physiology first year practicals itself. So in coordination with repetitive movement, that's how you're going to check. And there will be pass pointing. And of course, that is because of poor calculation of distance. Ametria will be, dysmetria will be there. That is the reason why you get this pass pointing. Or you can get this kind of rebound phenomenon, rebound effects. So these are the usual features of cerebellar involvement. Some of the points that tells you that's a cerebellar problem. And they can get that typical dysarthria, as I told you, that's a scanning or a staccato type of speech. That's a cerebellar type of dysarthria. And more importantly, what you should know is if you are talking about a lateral lesion, and we have very clearly seen that motor problems are basically medial. The corticospinal tract is in the medial. How can I get a motor problem in the lateral lesion? Except few variants. If you're talking about a typical lateral lesion, there will be no motor loss. In the sense, there will be no hemiparesis. That's very, very important because in exam, one of the very common questions that you will get is all of the following are features of Wallenberg syndrome except option C will be hemiparesis. Definitely it is wrong. How can you get hemiparesis in a lateral lesion? Because motor loss can happen only in a medial brainstem lesion. Then move to the other area. Suppose if my predominant cranial nerve that is affected is the 7th cranial nerve, and if it's the LMN, 5, 6, 7, 8 are basically present in the pons only. 6 in that is present on the medial side. 7, 8, 5, I told you they emerge from the lateral side. 5 we already discussed in the form of sensor loss in the face. Only 7 and 8 is there. So if I have predominant 7th cranial nerve involvement, I don't want 8th. So predominantly if there is 7th cranial nerve involvement, that's going to be the most prominent here. That will be called as lateral pontine syndrome. That will be a lateral pontine syndrome. Otherwise something called as a Mary-Fox disease. Like Wallenberg syndrome, that's called a Mary-Fox disease. That's a lateral pontine syndrome. So now you can tell lateral pontine syndrome very simply, same features. Ipsilateral loss of pain and temperature in the face, contralateral loss of pain and temperature in the body, then ipsilateral cerebellar symptoms, ipsilateral Horner syndrome, and you'll have a ipsilateral element type of 7th cranial nerve palsy. And 7th cranial nerve has one peculiar disadvantage. Why? Because you need to, that is the reason why you need to differentiate between a human 7th nerve palsy versus an element 7th nerve palsy. Remember, almost all the cranial nerves have bilateral projections in the sense like if you damage only one human fiber, other side human fiber may be able to compensate that. Element, no problem. Element, any cranial nerve will have a problem. You cannot talk about element here. As far as human is concerned, cutting off human on one side, you will not have any problem. I'm not telling you not have any problem. You will have very less problem. That is because majority of the cranial nucleus are bilaterally innervated from both the sides. So cutting off one human will not have significant impact for most of the cranial nerves. In fact, all of the cranial nerves because they have bilateral projections to the nucleus. But human anyway, element anyways, if you cut element, you're going to end up in significant issues because it's the terminal stage. Except one cranial nerve, that is a facial nerve, that is a CN7. Because cranial nerve number 7 has two types of projections to the nucleus. One, the upper face. Upper half of the face will have bilateral projection. So unilateral human lesions will not affect the upper half of the face. But lower half of the face is going to have unilateral projection only, which means like unlike other cranial nerves, you are not going to have bilateral projections for the lower half of the face only, which means that is the reason why majority of the hemiparesis that you see in your practice has problem in the lower half of the face. Other cranial nerves, generally they escape. They do have some deficits, but they escape because of the bilateral projection. But this is not applicable to LMN. LMN, any cranial nerve, if it's affected in LMN area, that will be definitely showing severe damage. So how will you differentiate? This idea is the one that's going to help us differentiate between human and element 7. If you think about a human 7, you're going to result only in the lower half of the face. Whereas if it's an element 7, that doesn't matter at all. You're going to involve both upper half as well as the lower half of the face without a doubt. So this will extrapolate to some clinical signs. For example, in human 7, I mean, there will be some common things. For example, if you see the deviation of the angle of the mouth, then here also you will see the deviation of the angle of the mouth to the other side. Then drooling of saliva can be seen in both, so that will not make any difference. Then loss of nasolabial folds will be seen in both, so that is not going to make any significant impact. But one important thing, that is your frowning will be intact in the setting of a human 7 because upper half of the face will not be affected. Whereas here it will be lost in LMN, and at the same time your closure of the eyes due to your opening of the eyes due to orbicularis oculi will not happen. So, and that will have a significant impact, which means you will see the Bell's phenomenon here in element 7. Bell's phenomenon. Clear? Clear not? You close your eyes with CN7 and open your eyes with cranial number 3. Isn't it? Cranial number 3, levator palpebral superior opens your eyes and you close your eyes with 7th cranial nerve. So closure will be defective, and whenever the patient tries to, I mean, this is a normal phenomenon. So whenever the patient closes, the eyeballs rotate upwards. That's a normal phenomenon, but not visible because the eyelids close properly. So that's Bell's phenomenon. It's normally not visible, but in element 7 involvement, Bell's phenomenon will become visible. Here, you will not have any problem. It will not be visible in the sense like the patient can close eyes normally. There won't be any issues because it's the upper half of the face. So these are very, very important points. So these are the two things that differentiate whether it's a human 7 versus element 7. Third point is drooling of saliva. Drooling, salivary drooling. And dysarthria can be seen in both. Dysarthria is due to involvement of the buccal musculature. Remember, the buccinator and this buccal musculature is basically lips buccal area is supplied by the facial nerve only. Orbicularis, oris, then buccinator are basically supplied by the facial nerve. And if you have weakness of the facial nerve, you will not be able to pronounce a letter called P. For example, if you want to tell pickup, these patients cannot tell pickup, they will tell fickup because their orbicularis, oris and buccinator muscles will be weak. That's why that whistling and all will be defective. So dysarthria will be there, that whistling will be defective. So all these things can be seen in both human 7 and element 7, but the most important thing that differentiates the human 7 from element 7 is this presence of Bell's phenomenon, and loss of frowning is the most important feature. And that will tell you that this patient is having a element 7 phenomenon. So in brainstem stroke, it's an element 7. And somebody asking again contralateral hemiparesis. Basically, we are talking about a lateral syndrome, a lateral lesion. And again you're asking whether hemiplegia will be seen or not. Again, Hershey is asking, Mary Fox will have hemiplegia will be. Why you want to have a hemiplegia? Why hemiparesis should be there? We are talking about a lateral lesion. The most important idea of a lateral lesion is not to have a hemiparesis. Motor is medial. That's why I told you M for M. Tit for tat. Lateral will not have hemiparesis. Lateral, both the lesions will not have hemiparesis, whatever we discussed till now. So it's very simple. Ultimately, it boils down to only one thing. So both lateral medullary and lateral pontine will have only same feature, but the only thing that differentiates the cranial involvement. If it's predominantly 9th and 10th, you go for medullary lesion. If it's predominantly 7th, you go for the pontine lesion. But the remaining feature is going to be the same. That ipsilateral loss of pain and temperature on face, contralateral loss of pain and temperature in the body, ipsilateral cerebellar symptom, ipsilateral Horner's, all are going to be the same. The only thing that's going to be different is the cranial nerve involvement. And of course, that is understandable because 7th is in the pons and 9th and 10th is in the medulla. So why you want so much? Why you are having so much difficulty in that? And now coming to the medial lesion. As far as the medial lesion is concerned, motor involvement is going to be the most prominent, which means hemiparesis is the most important here. Most of these lesions will have hemiparesis, and they'll have a contralateral hemiparesis. Because why you have contralateral hemiparesis? Because you're involving the motor pathway, and that is going to decussate in the lower part of the medulla only. So anywhere in the brainstem, if you affect this motor pathway, they will result only in contralateral hemiparesis because they have not yet crossed. So that's the most important here. So what you're going to see, a similar kind of a diagram you're going to see here, but this will be related to motor involvement. This is related to motor involvement. So I can draw a very, very similar diagram. So I can write, for example, I'll have cranial nerve involvement on one side, and I'll have hemiparesis on other side. So which means I can write here that my cranial nerve palsy will be on one side. Most of the time it will be a motor cranial nerve palsy like 3, 4, 6, and 12. That's what is going to be involved. And predominantly my hemiparesis will be on the other side, on the contralateral side, which means cranial nerves will always be ipsilateral and hemiparesis will be on the contralateral side because of the corticospinal tract involvement. And these patients can additionally, plus or minus, they can have medial lemniscus involvement. Medial lemniscus involvement. So if they have medial lemniscus involvement, it's the common entity in majority of the medial strokes. So that will not be able to differentiate stuff. So which means you're going to have a contralateral loss of posterior column sensations. We know what are posterior column sensations, and nobody can ever forget after my lecture. So these are posterior column sensations that is going to be lost on the contralateral side, and we know that for sure. So plus or minus medial lemniscus involvement. And now I need to know where the problem is, because I know now there is some cranopalsy on one side and I have hemiparesis on the other side. This kind of cross lesion means it must be equal to brainstem, nothing else. There can be no other area that you can get this kind of presentation. For example, you can get cranopalsy and you can get hemiparesis in a cortical lesion or even in a subcortical lesion above the brainstem. But basically, you will not have this kind of crossing. You will have the one particular side only. For example, face, body, both will have hemiparesis on right side, which means it's a left-sided cortical lesion or left-sided subcortical or internal capsule lesion. It will have right-sided facial nerve palsy and right-sided hemiparesis only. Whenever it is crossed, one side something, another side another thing, this face-body dissociation is there. That is equal to brainstem lesion. Below the brainstem, you will not get cranial nerve lesion at all in the first place. So that's out of the question. So now you know that you are dealing with some medial lesion. How will you know what medial lesion you are dealing with? So see our beautiful cranial nerves. That's all. So cranial nerves are going to tell you where the site of the lesion is. So now if you have a predominantly 12th nerve involvement, you know, like 3, 4, 6, and 12 are medial cranial nerves. In that 12th nerve is a medullary cranial nerve. So which means the lesion is in the medulla, which also means that you are dealing with something called a medial medullary syndrome. Otherwise, this is also referred to as something called a degerens anterior bulbar syndrome. This is also referred to as a degerens anterior bulbar syndrome. And what are the features of degerens anterior bulbar syndrome? Here, the cranial nerve palsy that you are encountering is 12, and the hemiparesis that you are seeing on the opposite, which means ipsilateral 12th nerve involvement with contralateral hemiparesis is what we refer to as degerens anterior bulbar syndrome. That's all, as simple as that. So that's 12th nerve involvement along with contralateral hemiparesis. Then if you have a 6th nerve involvement, then my lesion must be localized in the pons, of course. And if I have a 3rd cranial nerve involvement, my lesion, of course, should be in the midbrain. 4th nerve involvement is usually rare. It can happen as a part of brainstem strokes, but generally it is quite rare. You won't really get that much of 4th cranial nerve involvement because it is present on the dorsal aspect of the brainstem. In any named syndromes, 4th nerve involvement will not come, but in reality, you can see 4th nerve involvement very commonly. So as far as the classic medial brainstem syndromes are concerned, Pontine syndromes are concerned, the first thing is to tell whether the patient is having with MLF involvement or without MLF involvement. So yes, now only, Pranay asked MLF, I'm talking about MLF. I told you in that particular diagram itself, that MLF is strictly a structure of the ponds only. That's why I'm going to discuss in the pontine regions only. I'm not going to discuss in the other areas. So as far as MLF is concerned, we can see whether MLF is involved or not, whether MLF is not involved. So suppose if you do not have MLF involvement, or if you do have MLF involvement, then how will you divide these lesions? If you do not have MLF involvement, usually that syndrome is what we refer to as a Millard-Gubler syndrome. So basically, what do you mean by Millard-Gubler syndrome? Millard-Gubler syndrome is a syndrome that will involve, first of all, I need to tell with the seventh. Most of the times with seventh or without seventh, that's what I need to tell. So anyways, fine. Let us come back to that. So this is Millard-Gubler syndrome. So Millard-Gubler syndrome is basically going to have seventh nerve involvement plus sixth nerve involvement plus your MLF involvement as well. And they will have contralateral hemiparesis also. I can write sixth nerve involvement plus seventh nerve involvement plus contralateral hemiparesis. So this is Millard-Gubler syndrome. So you might ask me suddenly why this seventh nerve came here. Already we have discussed that seventh nerve in the lateral brainstem strokes itself. Suddenly this seventh nerve is popping up with the medial brainstem strokes in the pons. Of course, seventh is in the midbrain, pons only. There is no doubt about that. But why it is coming again here is because we know that the seventh cranial nerve takes a genu and goes to the lateral side, which means the seventh cranial nerve nucleus is present on the medial aspect only. But this nerve takes a genu and goes to the lateral side. So this is one cranial nerve that can be common for both lateral as well as medial syndromes. It can be affected both in medial syndromes as well as lateral syndromes. So that's why you need to know this. And this genu is the one that creates a sort of elevation in the brainstem, especially in the pons. That's called facial colliculus. Facial colliculus. These are nothing but the turning fibers of the seventh cranial nerve that are going from the medial towards the lateral side is what we refer to as a genu of the seventh cranial nerve. And that's very important to understand as well. Clear? So that's why seventh cranial nerve can be involved in both medial as well as lateral syndromes. If MLF is involved, then I need to see whether seventh nerve involvement will be there or not. So there are two syndromes. So see whether seventh nerve involvement is there or not. In this Millard-Gubler anyhow will have seventh nerve. So if seventh nerve involvement is there or not there. If seventh nerve involvement is there, then that is called as a Foville syndrome. So how can you remember this? In Foville syndrome, you can write like 7 itself. Like 7, if you write and put like this, you will have Foville's syndrome. So Foville syndrome will have seventh nerve involvement along with MLF involvement. How can you remember that Foville's will have MLF involvement also? Because Foville means F. F means you will have another fasciculus that will be involved here. That is a medial longitudinal fasciculus. So 1 F and 7, if you write, it will be like F. So both will be involved in Foville syndrome. As far as Millard-Gubler syndrome, it's very easy to understand Millard-Gubler syndrome. Where Millard stands, if you count the number of letters, 1, 2, 3, 4, 5, 6, Millard has 7 letters and Gubler has G-U-B-L-E-R has 6 letters. So 7 plus 6 plus contralateral hemiparesis is Millard-Gubler syndrome. So in that way, you can remember Millard-Gubler, Foville's 1 fasciculus and 7th nerve that is looking like F. So both will be involved in Foville syndrome. So Foville's is 6 plus 7 plus MLF involvement plus contralateral hemiparesis. This is Foville's. Seen on Millard-Gubler syndrome, will not forget. Sankhya is telling, okay. When seventh cranial nerve is not there, when seventh cranial nerve involvement is not there, that syndrome is what we refer to as something called a Raymond-Sestan syndrome. Raymond-Sestan. So in Raymond-Sestan syndrome, you will have only 6 plus MLF, but no 7 plus contralateral hemiparesis. So this is Raymond-Sestan syndrome. Easy to understand. So based on MLF, you can have different types of syndromes, and you can categorize based on that. And as far as the third cranial nerve syndromes are concerned, the most important syndrome is the Weber syndrome. So which means you are going to have a third cranial nerve involvement plus contralateral hemiparesis. So which means in this condition, the ipsilateral cranial nerve that is involved is the 3, and you'll have a contralateral hemiparesis, which is together referred to as a Weber syndrome. This is Weber syndrome. It is nothing but ipsilateral third nerve palsy plus contralateral hemiparesis. This is Weber syndrome. It's quite simple. And at the same time, you have some, variants of this brainstem strokes also. There are huge variants are there, but important ones I'm telling. There are some third nerve disorders, that is midbrain syndromes, that can have ataxia. Why you get ataxia? That is because of the cerebellar peduncle involvement. And there are some midbrain syndromes that can have red nucleus involvement. Yes, so there are two variants are there. The ones with red nucleus involvement is what we refer to as Benedict syndrome. Basically, Benedict syndrome will have third cranial nerve involvement, plus instead of contralateral hemiparesis, they will have contralateral tremors. Instead of hemiparesis, they will have contralateral tremors. How can you remember that they have contralateral tremors? Remember, this T stands for Benedict. You can remember like that because in Weber you don't have any T. So in Benedict you have T, so you can remember like tremors. Or you can also remember like old church fathers. Usually church fathers will be old and they are called as Benedicts. So old church fathers tend to have tremors. So you can remember like that also. There are many mnemonics for that. Third cranial nerve involvement plus contralateral tremors is basically Benedicts. And you have ataxic variants where instead of hemiparesis, you will have ataxia. They might have hemiparesis. I'm not telling they will not have hemiparesis. They might have hemiparesis, but these are mostly ataxic variants, which means you can have a third cranial nerve involvement plus if you have an ipsilateral ataxia or a contralateral ataxia. If you have an ipsilateral ataxia, that is called a North-Nagel syndrome. And if you have contralateral ataxia, that is called a Claude syndrome. And again, you have a mnemonic to understand this easily. For example, among all the syndrome, if you take Weber, Benedict, North-Nagel, Claude syndrome, only North-Nagel and Claude syndrome are having A in it. So that's why they are basically ataxic syndromes. So only North-Nagel and Claude will have, among the four syndromes you have described, only North-Nagel and Claude syndrome will have A in it. So these are ataxic syndromes, to be precise. And in that, how to remember ipsilateral versus contralateral? It's very easy. As I already told you, Claude has CLA in it. So you have contralateral ataxia in it. So that's going to produce contralateral ataxia. That is called a Claude syndrome. So now you'll be able to identify all the syndromes. It's very simple. So you know what is lateral medullary syndrome, what is medial medullary, what is pontine, what is medial pontine syndromes you have. Why contralateral and Claude? Because you're going to have this crossing fibers. As far as midbrain is concerned, the cerebellar peduncles will be having this kind of crossing fibers. Even though they cross like this from superior cerebellar peduncle, they go to the other side of the cerebellum. And from the other side of the cerebellum, they go back to the same side. Still, it will be, if it affects the cerebellum, it will be still ipsilateral only. But if these crossing fibers are affected, sometimes you might result in contralateral type of ataxia in the midbrain. Only in the midbrain, if you go and study in the superior cerebellar peduncle alone, they would have given like this. Yes, but if you take the North-Nagel syndrome, it will be basically in the peduncle itself, not in the crossing fibers here. So that is the reason why you will get ipsilateral ataxia over there. And it's all anatomy only, basic anatomy. And nobody is going to ask you why and all, but just it's better to remember for exams. And these syndromes are extremely rare syndromes. And how much ever you try to understand, it will not make sense, number one. Second thing, there is no point in wasting so much time on these syndromes, number two. Number three, at the same time, the treatment is going to be the same, irrespective of whether you know all this or whether you don't know all this. The final idea is to identify that there is a stroke and the patient should be treated in the same similar way. There's not going to have any management impact also. So I feel like this is not really needed that much. So this is very easy to understand. So this is how you divide the brainstem lesions in the first place. Sequentially, we have told posterior circulation stroke, how to divide and how to see P1 syndromes, P2 syndromes, then go to the brainstem syndromes, and finally come to the each and every level. And more importantly, if you want to tell the artery of involvement, it's very simple. We have already discussed that arteries. So anything that is considered the lateral part of the medulla is going to be pica, medial part of the medulla is going to be anterior-spinal artery, lateral part of the pons is going to be ICA, medial part of the pons is going to be basilar, and anywhere in the midbrain it's going to be the posterior cerebral artery. That is the P1 segment of the posterior cerebral artery. These are the perforating branches, which means I can really tell that if it's going to be the lateral medullary syndrome, the most important artery of involvement will be pica. That's what will be asked in exams. But even though research tells that vertebral artery involvement is more common than the pica, even though Wallenberg first described this case with pica occlusion, still this syndrome is called as pica syndrome. But according to research, vertebral artery is more commonly involved in lateral medullary syndrome compared to pica. And as far as the lateral pontine syndrome is concerned, you know very nicely, this syndrome must be due to ICA involvement. So that is why this is also referred to as ICA syndrome, whereas lateral medullary syndrome is also referred to as a pica syndrome. And as far as the medial medullary syndrome is concerned, you will be typically having anterior spinal artery involvement. So we have seen already medial part of the medulla supplied by ASA, and anywhere, whatever may be the medial pontine syndrome, the artery of involvement usually will be basilar artery. These are the perforating or penetrating branches of the basilar artery as the one that's going to be the reason for development of any of these syndromes. And any midbrain syndrome, we know very well that's going to be the P1 segment of the PCA. That's going to be the artery of occlusion. So you can tell the arteries also very easily because I've told you the basics beforehand itself. So that should not be a big issue basically. Okay, now you know all the syndromes, the most important ones, and I don't think they will be asking you the names of these syndromes. Stammering does not come under dysarthria. That's a separate entity. It's not dysarthria. Anyways, so these are the different types of brainstem strokes, and I don't think they will ask you the intricate details of all the brainstem strokes. Don't waste a lot of time on that. If at all they want to ask, they will be asking you the Wallenberg syndrome, which is more important. The lateral pontine syndrome, they'll ask you, which is the most important. They'll ask Millard-Gubler syndrome, Fowell syndrome, and probably Weber syndrome. So if at all you are in an urgency and you want to study, these are the syndromes you need to concentrate for exams. If you want to study only one out of all, then study the lateral medullary syndrome. That's going to be the most important. If you want to study only one, then in that setting, it will be the lateral pontine syndrome. That's going to be the most important. Lateral medullary syndrome, that's going to be the most important. Clear? So I think our brainstem strokes are over. So we have completed the stroke localization. I think with this we can close the session because tomorrow we need to discuss on the stroke treatment, and after that we'll be discussing on the other aspects of neurology like multiple sclerosis. Then we have peripheral neuropathies, neuromuscular junction disorders. So we'll try to finish off by tomorrow itself, all this stuff. Okay, fine. See you all. Good night. Bye-bye. What time? Same. I'll try to, I usually come around 10 o'clock here. Sharp, I'll be 10, 10, 5, usually 10 to come here, but it's all about the, depending on the internet connection, because the 10 to 11 is always having an internet connection. So if internet connection is good, then we'll start by 10, 10, 10, 5 itself. If internet connection is bad, then it might take some time. So same issue. Thank you. Bye-bye. Good night.